All right, so welcome to lecture 13 or week 13. And as always, I like to provide a tune, a little music that is associated with infectious diseases. My pick for this week is Maybe It's a Virus by Julia Haltigan and the Hooligans. Very catchy, very upbeat. So if you have a moment, you might want to listen to this. Now, this should make you kind of happy and excited. So we are here and we really only have one full week, and the following week, that is finals. Now, just a little reminder, your research paper will be due before Wednesday of that week at 11:59 p.m. But hey, there's nothing else going on from this class that week. And once you have that paper in, my goodness, maybe you can even enjoy some spring weather, assuming we have any spring weather. Tomorrow is Sunday and we're looking at snow again. Ah, what a long winter this has been. But we're getting there. We're going to be done with winter. We're going to be done with the class, and yay. Maybe you can go celebrate. So here are the objectives. This is the weekly assignment. I might tweak that a little bit. Still, before you'll get that, it'll be posted. Here are some terms. We'll see how far we get. I will let you know, as I was looking at all the material, I realized there's really not any way that we're going to get through everything I would like to. For example, all of the types of hypersensitivity. There is no way we're going to do this. So my thought was I would spend a lot of time on allergies. That is the most common problem that you will encounter when the immune system gets a little confused. So that's the most common hypersensitivity. The second, third, and fourth types of hypersensitivities I will talk about, but it's only FYI only. So you might want to listen to it because I know that these are conditions that you come up against all the time in your clinical careers. So you probably, I would hope you have some curiosity about what is going on, and I will try to explain, these types of hypersensitivities. But you will not be, you are not responsible for types 2, 3, and 4 for the quiz. Okay? So, all right. Now, also, so this whole the today's lecture, these lectures, we're going to begin by going back and talking about vaccines just a little bit and the immune response. And then we're going to segue into what happens when the immune system gets a little confused and you can have diseases of the immune system. Okay. And following that, we'll talk about infectious diseases. We're into the grab bag part. Yay! So, this is a little cartoon that I found that was adorable. And here it has a little memory B cell. And he's kind of relaxing. And all right. So, what happens though is if he gets triggered, so here's the memory B cell, and he gets a call. Maybe that's from cytokine signals, right? So he gets the call and he realizes, oh, right, he has to spring into action and he remembers what this particular invader looked like. So he's going to make all the antibodies to label it for destruction. Okay. So after clearing the body of an invading organism, the B cell retains memory of its target and rests until another infection occurs. This is what vaccines are all about. Remember, vaccines are to protect against disease, provide memory to the immune system, so that if it ever comes back, you can fight it and hopefully not even have symptoms. So, like I said, I did want to just follow up a little bit, a few final words about vaccines. So, a lot of people out there do believe that we should stop giving vaccines and let nature take its course. Actually, just today I went to my hairstylist getting my roots done, And she's pregnant, and somebody said, well, yeah, I mean, what did we do? What did they do 200 years ago? Why do we need all this? And she's not an immunologist, clearly, but she just looked at them and she just says, well, we died. That's what we did. Uh, so, and that is true with infectious diseases swept through and killed people. I mean, you'd be lucky to live to a ripe old age of 30. So that's what we did in the good old days. So, should we let nature take its course? This is a wonderful little table that I wanted to provide for you, and it's also a reminder that vaccine technology is an extremely powerful and life-saving tool. It should never be taken lightly because we are kind of tweaking the immune system. But like I mentioned before, how nice is it to be able to provide memory cells, to make memory cells without getting the disease? So that way, if the really nasty thing comes our way, oh, take it out, not a symptom. So this table has the historical comparisons of morbidity and mortality for preventable diseases. And these are with vaccines licensed or recommended before 1980. So this is just looking at some of the major infectious diseases and what we saw before and after. Um, what we basically saw before vaccines. So this is pretty much an annual average cases and deaths. And as far as how much reduction of diphtheria, it's pretty much in this country, we've reduced this to 100%. We've reduced it 100%. Measles, 99.9 cases. So we've reduced it. We've reduced the number of measles cases 99.9%. So there's still that 0.1%. As far as deaths, we've reduced that 100%. So yeah, we don't see this on average. It's not to say it doesn't happen, but statistically, we really don't see that every year. Mumps, pertussis, or whooping cough, polio. Really, polio is almost eradicated through off the planet. So that, oh, sorry, polio, yeah, polio down here, almost eradicated off the planet. Rubella, congenital rubella syndrome, smallpox. Smallpox, nobody even gets that vaccine anymore, remember, because, okay, we've eradicated it. And tetanus, we never saw a lot of cases, but it's so awful that thank goodness we really have reduced what few cases we had because it's a terrible disease. Okay, and this is from JAMA. So so this is from and posted from the American Medical Association. Okay, so I know this picture is just horrible, and I'm sorry. It's like but I just wanted to point something out. I heard someone say at a talk that to produce fear in a person takes minutes, maybe seconds. Education takes a lifetime. And when we're looking at young babies, of course, everything in our bodies, all of our natural instincts say we must save and protect these babies because they're just, of course, this is just natural. If you're a normal human being and not a sociopath, this is what you should always be thinking. Unfortunately, that little bit of fear can sometimes distract you from even hearing evidence and contradictory evidence, right? So, yeah, education can take so long, and it's very difficult. As an educator, I can tell you it is really hard. But educating people against some fear that has set in, okay, that's really hard to do because they've always heard, there's that person who said this and this happened to that other person, and a lot of anecdotal evidence, anecdotal information. But when it comes to real research where you have double blind tests and it's confirmed in other laboratories. Okay, sometimes you don't find that evidence, but you still hear the person who the cousin of the person this happened to, and you read this and it was online, and yeah, it's rather difficult. This sort of rhetoric does grab your attention, and People who want to sell you things, politicians, they know that to make you afraid is a good way to make a person act. Make make you afraid that if you don't buy the car today, if you don't buy the house today, if you don't vote this way, your whole life is going to fall apart. This is how things get sold to you. And again, with this is hard to overcome. It just is. So, where do you turn for information about vaccines? There are lots and lots of websites with lots and lots of information. People and Health Freedom USA. This is very interesting. When you go onto the website, they actually have real scientific information, like for example about viruses, and they will tell you some real information. They'll quote the CDC and USDA and all of that, but then it starts to go south. So you have to be careful. People will mix, some very inaccurate information with accurate information, and unless you're someone who is going to school and you are trained to look up and confirm information. You look at peer-reviewed articles. You see what the expert opinions are. Okay, unless you're one of those people, you would totally buy into this because why wouldn't you? How many people out there understand how the immune system works? They know the difference between humoral and cell-mediated immunity. How many people know that proteins are the best antigens, whereas sugars are not? And okay, all of this, you just wouldn't know. So, unfortunately, websites like this can convince people very easily. The pharmaceutical industry, again, they're the ones manufacturing the stuff. So, yes, I mean, they do a lot of tests and a lot of research. And and they do tell you, I mean, they will tell you the side effects. All you have to do is look. All medication has side effects. All medication has side effects. Okay, aspirin has side effects. And no vaccine manufacturer is going to hide the possible side effects from you. They're just not. So they're there. Um, but they're not my favorite source. So the government, FDA, CDC, usually World Health Organization, usually good sources. This is my favorite though, from the University of Pennsylvania Center for Bioethics, Ethics of Vaccines Project, and this just basically says vaccines are so important. That this technology is something that we need to use. It could be improved quite a lot. It has problems. So they're going to be the first to say, well, there are always ways to improve. And I really like what they do. So this is a good source. Okay, so now let's talk about measuring immunocompetence. As the name implies, okay, how do we measure that someone's immune system has responded appropriately either to a natural exposure to a pathogen, like somebody sneezed on you, or or maybe a vaccine? Okay, so you got the vaccine, but did you respond to the vaccine? Maybe somebody, they checked your blood and you had to go back and get a booster, and then another one, and then another one. Something was going on with your immunocompetence. So let's define this. Immunocompetence is how well you respond to an invader. Again, this could be natural or this could be through a vaccine. So, why is it some people respond better than others to exposure? I mean, some people respond, they get the memory cells going, and the memory cells are really good and they activate when you are exposed to the invader a second time. And then again, they're really good even the third time around. You don't even get a symptom. So, all right, some people are very immunocompetent. Yeah, they get chickenpox once, never again. Some people, they got chicken pox the first time and then they had chicken pox again. It's rare, but maybe even a third time. Well, they weren't as immunocompetent. Why? Well, it's always genetics and environment. One of the things that could happen is the invader got into the body. either through the natural route or through a vaccine. And okay, let's say it got into me, and maybe through a vaccine. Do my lymphocytes have a good receptor? My B and my T cells, if they have good receptors, then and the right receptors, then they could get cracking, right? And we could start to make, the helper T cells can talk to the B cells. The B cells then can make plasma cells, and plasma cells can make antibodies and memory for the next time around. So, okay, correct receptors. So again, if I have the correct receptors, I can make memory, and also, I have a lot of antibodies made. Okay, I respond very well. My adaptive immune response is just really, really good. And a lot of times this has to do with genes. Whether you have the right receptors, you're good at making memory cells, and from there making antibodies to patrol your serum, your liquidy part of your blood, right? Also, your overall health, eating right, exercising, eating right is going to feed your white blood cells, your military people, your lymphocytes. Uh, you know, Getting, exercising is going to cause good circulation. So your soldiers get to all the deep tissue places and they do their job. So yeah, overall health, that's very important too. And again, back to nutrition. Feed your white blood cells. Okay. So, how are we going to measure immunocompetence? Well, again, you can get the same, like if you get chicken pox twice, you're not very immunocompetent, but that doesn't work for a clinical lab. That doesn't work if you're going to go into nursing and they want to check to make sure that that your vaccines are updated and that you are actually protected. So, when you first start nursing school, right, they sent you to go get your blood tested. They wanted to check your plasma, and they did that. So they looked for antibodies in the serum. Again, serum is the liquidy part, not the white blood cells or the red blood cells. It's the liquidy part. So they're going to look for the protein antibodies in the serum. Do you have antibodies in your serum that respond to hepatitis A? If not, go back and get a booster. How about hepatitis B? If not, go back and get a booster. DPT, MMR, chickenpox, all of those. So they're going to check to see if you have the antibodies in your titer. This is what, when you measure antibodies, we call that the titer. The titer is the measurement of antibodies in the serum. Okay. Now, how do they do this? And to do this in a laboratory to see if you have these antibodies can be done in many different ways. One of the ways that you could use is somewhat similar to what was done when you checked to see if you were A type or B type in anatomy and physiology. It was a little reaction between your blood cell antigens and antibodies that they had. And these were agglutination tests. Let me kind of go back. Oh, that didn't come up very well. But okay, so one of the things they can do is they can have a little test tube, or they're actually called these little tiny wells, and they can put an antigen in here. Maybe this is maybe it's a hepatitis B antigen. It's got all the ID tags. And then they'd run your serum over this. And if your serum has the antibody, then it would attach to the hepatitis B. And you get this clumping, and that's an agglutination. That's one way to do it. Actually, they don't do that as much as other ways. Sometimes they will put little tags on the antigens so that the antigens and the antibodies clump together. You get a kind of a bright glowy color. And so this is one way to do this, is an agglutination test between antigens and serum antibodies. In your reading, you might have come across this. These are called ELISA tests when they do this, ELISA tests. So, all right. So let's say that you got a needle stick. Oh no. And you're wondering if unfortunately, you might have been exposed to a hepatitis virus. So what do you do? Well, if they take your plasma, if they look at your serum, they wouldn't see antibodies yet, would they? Not right after the needle stick. It takes a little while. So if at the needle stick the virus got in, then it has to find a dendritic cell. The dendritic cell then has to find a helper T cell. They shake hands, they talk, and then the helper T cell has to go tell the B cells, hey, you need to respond and help to make antibodies. The B cells then are converted to plasma cells. All the antibodies are made. They're released in the serum. Okay, so that takes a while. That takes a while. So this is called serum conversion. Serum conversion is the amount of time it takes from the exposure to the time you finally have enough antibodies in your serum to know that, okay, you did respond to hepatitis because you have antibodies against hepatitis in your serum. Yeah. So you got the needle stick, and now several weeks later, you have antibodies against hepatitis that weren't there before. So clearly, you were exposed to hepatitis and you have now serum conversion. Okay. So if we find the hepatitis antibodies in your serum, that means you've been exposed, and which is unfortunate. Okay, so here's a question. Someone who responds well to a natural antigen exposure or to an artificial vaccine and who makes good memory cells would be considered A, immunocompetent, B, immunodeficient, C, immunoconverted, D, immunoshielded, E, immunodesensitized. Well, of course, that's immunocompetent. So your immune system is competent. You made the memory cells. Good. All right, following a needle stick, it may take a few weeks before the body starts to make enough serum antibodies needed to detect hepatitis virus exposure. So this is called A, serum conversion, B, serum sensitization, C, serum desensitization, D, serum flipping, E, serum titering. Well, now titer is the measurement of how many antibodies are in the serum. But no, this is the time it takes to make enough serum antibodies. So this is serum conversion. By the way, even after serum conversion, you may not have enough antibodies in your serum. We would say that you have a low titer. You're still going to have to go back and probably get that booster. Shucky darn. Yeah. How would we describe a patient with many, many antibodies against HIV? A, they have a high antibody titer. B, they have serum converted. C, they have immunity to HIV. D, they have not serum converted yet. E, A, and B are correct. Well, and as I said, this would be A. They have a high antibody titer if you have many, many antibodies against HIV. But unfortunately, that doesn't mean that you have immunity. That just means the antibodies in the serum. Remember, HIV hides inside white blood cells. So just having the antibodies floating around isn't going to help you if the darn virus is hiding inside of one of your good guy cells, right? Okay, well, I know we can, yes, take a look at this very shocking picture here. This is someone being tested for allergens. Yeah, allergies. What is going on with allergies? Well, this is an example of what happens when the immune system messes up. Actually, the immune system is a very powerful system, and there's a very fine balance going on. And if it goes out of whack, serious things can happen. Anything from, all right, a little bit of hay fever to dying. So, this is what we're going to talk about. We're going to talk about immune system disorders. Okay? And okay, I feel sorry for that person. All right, so immune system disorders. Why are some people allergic to peanuts or penicillin? Why is that? Well, we're going to talk about that. Why do people get autoimmune disease? Well, that's a very good question. We're going to try to answer some of this, at least some of it. We're still working on it. And why, again, do some people never seem to get an infectious disease? How annoying. My sister was like that growing up, and I got everything. And like I said, scientists are still working on some of these answers. Research dollars, you need to have the money, you know, in order to pay for people to run research labs, unfortunately. And we don't always have the money. We don't have a lot of financing. A lot of research is run by the government. There are government grants that researchers can apply to, but the approval of research grants has really declined, and only a handful of people get research money anymore. That's why, well, it's one of the reasons I got out of research. There just isn't a lot of money out there. That and the fact that my boss kept getting promoted. And I love teaching. So, hey, I'm in a good place. So, all right. So, when it comes to, why all these things happen, we know two things are involved. Number one is genetics. There's always a genetics component, and it always also links to environment. Okay. So when the immune system goes out of whack, it's always, it's almost always between these two. And even if there is something that's primarily genetics and it leans very heavily towards genetics, we know that, oh, if you can improve some environmental factors, it makes the condition a little better. Okay. So it's always these two, always. So we're going to address what we understand so far, and there's a lot to talk about. I'm going to divide this into three different categories when it comes to what happens when the immune system goes a little crazy. So number one is you can have hypersensitivity. So the immune system goes a little crazy, and you get an immune response that injures. And the immune response occurs because you are somehow sensitive to an allergen. Okay, an allergen is anything that generates an allergy. So it's going to trigger, there's something in the environment that's going to trigger this crazy immune response called a hypersensitivity. And here's a good example. You see Will Smith kind of responding badly to an environment. I think it was a bee sting. So normally what's going on is something harmless in the environment is causing all of this. In some cases, you can progress from like a mild case of hives to anaphylaxis. Now, anaphylaxis, if you don't know what that is, we will talk about that later. So, hypersensitivities have to do with antibodies. You can have especially IgGs and IgEs. Remember, IgEs are always there when there's a parasite or allergies, right? So antibodies can be involved. There's a one type of hypersensitivity though that does not involve antibodies. It means that what happens is the cytotoxic T cells and the natural killer cells that are carrying those granzymes and perforin, they start going after tissue directly with the granzymes and with the perforin. So this is pretty dramatic. So these are hypersensitivities. We're also going to look at autoimmune disease targets. So autoimmune means that for whatever reason, we're not going after like peanuts or bee proteins. For whatever reason, the immune system starts to look at your own cells as foreign. So that's called, and you attack your own cells. This is called autoimmune disease, okay? And then finally, we'll talk about immunodeficiencies at the very end. So this means that you don't have an adequate immune response, okay? So first of all, hypersensitivity or hypersensitivities. So this is your body going in and thinking, all right, there's something really bad. We need to go blow it up. well, then you get this big inflammatory response here going on. You get the redness and the itchiness, and all of the soldiers are there fighting this battle. And it could be because you were encountered something weird in the washing detergent, and yeah, so you get something like this. So hypersensitivities. We're going to stress type 1. There's type 1, type 2, type 3, and type 4. Type 1, I'm going to spend the most time on. Types 2, 3, and 4, I'm going to mention briefly, but you will not be responsible for these types on the quiz. I know, yay. However, I do want to talk about it. Some of these you will encounter in your clinical life. Hopefully, you've had this in physiology at some point. Um, if not, we'll talk about these. All right. So one way that you can learn hypersensitivity, or the four types of hypersensitivities. There's type 1, 2, 3, and 4, as I mentioned, but you can think of the mnemonic acid. So A for allergic. Type 1 is allergic. And okay, so the allergic kind we're going to spend the most time on. These are going to have the IgE antibodies and granulocytes. This is going to occur very, very quickly. So the triggers for allergic responses are many, 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 many. I'm only going to talk about a few, but for example, latex. Okay, little latex molecules, bee sting proteins, penicillin, so forth and so on. Type 2, this is, okay, A and C. Type 2 is cytotoxic, antibody mediated. So this also will have to do with antibodies, but mostly IgM and IgG. This is what happens when you get transplants. You get the wrong blood type. And so the immune system is looking at maybe the B blood coming in and you have A blood normally. So the B blood antigens are foreign. This can also happen if you have a graft rejection. Okay. And some of these, by the way, do overlap. So that's why I'm not spending as much time as I would like. I'm trying to keep it simple. Type 3, this is the I and acid. These are immune complexes. So here again, you can get IgMs and IgGs coming together where they form, you know, big chunks of things that can mess up tissue. So if you've heard of lupus, this is an example of type 3. Type 4 is the one that does not involve antibodies, but instead these are the cells of the adaptive immune response. So we have T cells and even natural killer cells that can get involved in this. So this takes a while. So it's called delayed hypersensitivity. Mind you, all of these occur because of your adaptive immune response. So remember the last week's lecture material, and I said that adaptive means that you get better at it. With every exposure, you get a stronger and stronger reaction, which is great if it's a chickenpox virus. You'll get a stronger and better reaction every time so that you do not have symptoms. But what if your body is recognizing the wrong thing? And every time it comes in contact with the wrong thing, you get a stronger, more violent reaction. Well, that's what happens with hypersensitivities. So your first exposure may not have been a big thing, but the second exposure, bad. Third exposure, really bad. Fourth exposure, you better hope you have an EpiPen, right? Okay, so this is all part of that adaptive immune system. You get better, and unfortunately, this means that you also freak out more. All right, so type 1 hypersensitivity. This is the one we're going to talk about the most. This is A, right? ACID, A for acid. And remember, this one is going to occur because of IgE antibodies. IgEs, we see these most often in allergies and parasites. Yes, indeedy. All right. So type 1 hypersensitivity is very fast. We're talking this can occur within 24 hours. If you're going to have a really violent reaction, it takes about 30 minutes. But Yeah, but still, you'll have some reaction within 24 hours, whether it's severe or even mild, within 24 hours after exposure. Okay. Now, if it's going to be really bad, that probably means you've been exposed before. You're going to have a fast response because unfortunately your memory cells remember this, and there's more to it too. But that can happen within minutes. Okay, really fast. As I said, this is going to involve IgE antibodies. And what they're going to do is they're going to, remember how the antibodies look like little Y-shaped proteins? Because they are Y-shaped proteins. And they have the little stem, okay? The little stem is the constant portion. Now, what happens is when the IgE antibodies are made after the first exposure, they will attach to granulocytes, sort of like arming granulocytes. Now, if you remember, granulocytes carry, or they're carrying chemical weapons. If these weapons are released, the granulocyte is going to die, and even the tissue cells around them are going to die. These are very powerful weapons. Okay. They'll also release prostaglandins and histamine, and you're going to get a big battle, right? It's going to, although there really wasn't an enemy there, it's kind of like fighting an all out war over a dummy or something. So again, what's going to happen is this is going to all trigger inflammation once the granulocytes degranulate. And we think perhaps what happens is your immune system might think it's a parasitic worm. I know that's weird, but that's going to come up when we talk about hygiene hypothesis. Why would I think that? Well, look at this eosinophil. Okay, eosinophil is more common when there is a parasite or an allergy. IgE antibodies, we see these when there's a parasite or an allergy. So, little link there. Okay, so the cause of type 1 hypersensitivity, you have environment with allergens. Okay, so, for example, you inhale pollen or cat dander or mold or ingest a peanut with peanut proteins, or milk with milk proteins, or seafood with seafood proteins. And now, why am I saying proteins? Remember from the last chapter, proteins make the biggest, bestest allergens. If it's a big protein and your immune system, for whatever reason, thinks that it's something more, more than what it is, it thinks that maybe it's a virus or a bacterial cell wall, it'll go crazy over this. I know, just little bits of protein and, pollen and or your pet or something like that. Um, you can also get injected allergens. So this could be due to an venom, bee sting, for example, or drugs. Okay, a drug was injected. Yeah, okay. That could definitely trigger a type 1 hypersensitivity allergy. Okay. And there's always a genetic component. We do know that, for example, if the parents have asthma, chances are the children will too. So we do know that it's environment and genetics. Usually it all comes together, like I said before. I know. Okay, so let's go through the steps. So what happens? And why is it that we can be exposed the first time? And, for example, maybe you were exposed to a bee sting, not a problem the first time. Second time there was a problem. Or you had a cat and it wasn't a problem, and then all of a sudden it was a problem. Or you used to be able to have peanuts and now you can't. So what's going on? For me, by the way, it was poison ivy. The first time through poison ivy, nah, really, no battles were going on. It wasn't a big deal. But the second time, it was a big deal. So for an allergic reaction to happen, first of all, a patient has to be sensitized. That means they were exposed the very first time to the allergen. In this particular case, cat dander. So sensitization is when you are first in contact with the allergen. Normally, again, it's usually a complex protein that does this. And this is going to trigger an antibody response. So you're going to make antibodies. Interestingly enough, you tend to make IgE antibodies. Remember? Allergies, IgE antibodies. Yeah. So those are made, and the IgE antibodies will attach by their constant region to one of the granulocytes. So remember the soldier that has the granules, and inside the granules, there are all of those chemicals. Some of these are chemical weapons. So this is sort of getting it all ready to go, this little granulocyte. Um, it turns out the reason this happens, now why are IgE antibodies made and not IgMs and then IgGs? Well, we think the B cells under mucous membranes, for whatever reason, they do something called class switching. They, instead of making the IgMs or IgGs, they, for whatever reason, the B cells probably are getting bad information from a helper T cell, and they think, oh, okay, so we need to switch to IgE antibody production right now, okay, to take these out. And again, maybe they think it's a parasite. So instead of making nice IgEs or IgGs or something, the IgEs are made, and their constant region attaches to the granulocyte. And they just accumulate. You get more and more IgE antibodies, and they attach to more and more granulocytes like eosinophils, mast cells, and basophils. So they're all set to go. So that when you get the second exposure, okay, oh, sorry, more antibodies. The second exposure means, okay, so you've inhaled cat dander, and this time it attaches directly to the variable region of an IgE antibody. What's that going to do to the granulocyte? Oh, sorry. Okay, the granulocyte then triggers and releases its granules. And there's, like I said, lots of chemical weapons in there. Histamine, that's going to cause vasodilation, leaky sort of blood vessels so that all the soldiers get to this particular area, and a whole battle occurs. These granulocytes, or these granules, can also contain chemicals that will kill neighboring cells. So you're going to have a big battle here. Okay, let's say this is in your mucous membrane in your nose. Okay, you're going to get a big battle. So you get swelling, redness, pain, extra mucus production from your goblet cells, and basically it's inflammation, all because of a cat protein. All right, so this is something a little different. You can get an allergic reaction on your skin. When you get an allergic reaction like this on your skin, it's called hives. So it's a skin condition. And how do we know it's hives? Well, it's characterized by something called a wheal and flare lesion. So the wheal looks like a blister, but it's hard and pale. And then around that you get the redness. That's the flare. Even kind of sounds like flare, doesn't it? So this is one of those very typical symptoms of hives. Okay. This individual here has just had a allergen skin test. So very easily seen in positive skin tests for allergens. Now, if you get hives, you can take something called an antihistamine, right? Right. Here's the cat dander, and it's bound to the IgE antibodies, and the granulocyte has dislodged all of the granule material, including histamine. But if you can take an antihistamine, then even if this granulocyte comes in contact, well, I should say, even if the cat dander does bind to the IgE, the granulocyte will not degranulate. So the antihistamine will block that. And so that will help with hives. If this happens in like your nose, you inhale it and you start to get a reaction in your eyes, in your nose, and it's itchy, it's watery, you start sneezing, this is called commonly known as hay fever. Okay, due to an airborne allergen. Okay, hive skin, hay fever. Okay, you've kind of, it's airborne. Okay, and again, block the antihistamines. Therefore, the blood vessels don't dilate. You don't get all the red blood cells here. You don't get the big battle. Okay, you don't get the swelling, the redness, all of that. Now, asthma occurs if this is you again, it's airborne. There's an airborne allergen, but it's getting into the respiratory tract, and it's going to be rather more serious. Okay, from rather more to very serious. So when the allergen causes uh, an inflammatory response in the respiratory tract, you're going to get spasms of the bronchial tubes, extra mucus production by the goblet cells, and with that, okay, that's going to block the respiratory tract, right? And you're going to get a lot of mucus. How are you going to be able to breathe comfortably? Well, you can't use antihistamines. That's not going to work because the antihistamines are only going to stop the vasodilation and a few other things from occurring. It's not going to have any impact on, for example, the soft tissue around the bronchial tubes. It's not going to help with that response with asthma. So an antihistamine isn't going to work. Maybe corticosteroids, which I will address coming up in a little bit. But yeah, there's too many other, with the asthma response, you're getting a lot of cytokines, you're getting a huge inflammatory response, and it's not just the histamine being released from the granulocytes. There's a lot more, so you need to suppress the immune system, many branches of the immune system with corticosteroids. Okay, so again, what's going to trigger an allergy? A type 1 hypersensitivity. I mentioned before, proteins, always the best trigger. Just like proteins make the best type of vaccine because that will trigger your adaptive immune response. Well, same thing, unfortunately, proteins make the best allergens or the worst allergens, however you want to put it. Now, there's also something that might happen. Some people respond to like a type of chemical that isn't even organic. It's not a protein, it's not even a lipid or even a carb. It's something inorganic. And people still respond very badly to it, like penicillin. The reason for that is there are chemicals that will latch onto fluid proteins. So in your tissue, you have proteins floating around. And sometimes there are drugs and chemicals that will latch onto these proteins and make these proteins into this huge, huge complex protein that will look like an allergen. That is an allergen. It tends to look like an invader to the body and to the immune response, and you get a type 1 hypersensitivity or allergy. All right, so this is just kind of going through some of the things that can happen with an allergy. So you have cat allergies. Here we have cat dander going up the nose. And again, the first time around is sensitivity, but during the sensitivity portion, you get all the IgE antibodies made and they arm the granulocytes so that the next time the cat dander is encountered, then you get a trigger of the granulocytes and all the chemicals are released. So you have these big battles all throughout the mucosal membrane. So, yep, allergy. Penicillin, like I mentioned before, there are chemicals out there that will uh, clump up with proteins in the body, although I only have penicillin here. And this is how people get penicillin allergies. The first time they take it, or even second or third, it's okay, but sometimes the penicillin binds with stuff in the body, forms a really weird looking complex, and it generates an allergy. So it's an allergen. So it's not the drug's fault, it's your body's immune response. Yeah. So it just got tricked. Remember, this is when we talk about hypersensitivities, you're responding to something that should be harmless. But again, the same thing happens, degranulation. And you can insert just whatever allergen you want in here. Okay, this is just for generic purposes. And again, this all came from Nature Medicine, and the title is Nipping Cat Allergy with Fusion Proteins. The article is more complex than you need, but the illustration is quite lovely, so I thought that would be helpful. All right, so what happens if you have an allergy that is life-threatening? Yeah, so you can get something called systemic anaphylaxis. Again, we're talking the IgE antibodies and the granulocytes. Yeah. So when this happens, you're not just, you're releasing so much out of the granulocytes that you get sort of a extensive blood vessel dilation problem. And okay, when that happens, so your blood vessels are opening, what's that going to do? Well, you're going to get a severe fluid loss, right? And with big, big, big tubes, your blood vessel tubes, if you expand those, then the blood pressure is going to drop. That's not good. Yeah, because that'll cause shock. Okay, so that is not good, anaphylaxis. So this is so, and there's other factors that are going on here as well. It's not just the IgE and the granulocytes. You have to do more. Um, Again, how are you going to counteract the insufficient blood flow? Taking an antihistamine isn't going to do any good. So at this point, you can go into anaphylactic shock. Anaphylactic shock means, yes, insufficient blood flow. During this time, also, the bronchial tubes will constrict. That'll, of course, cause suffocation. And your normal allergens can cause this. Bee sting, venom, which is usually the protein component, peanut proteins, penicillin injections will do it. And those three are actually the biggest causes of anaphylactic shock. All right. So this just shows signs and symptoms of anaphylaxis. So it's very severe. Taking antihistamines is not going to do it. What you need to do is get an injection of epinephrine. Okay, so this is like your EpiPen. You're getting adrenaline. If you do that, then your muscle, the muscle cells around the blood vessels will contract. Okay, and that means that, okay, so now the blood vessels aren't big, they're smaller, and that's going to increase your blood pressure, right? So your blood pressure goes back up. All right, whew, and that's going to increase your cardiac output and shock risk decreased. So probably a lot of you know people who have to carry EpiPens. Yeah, and this is why. And like I said before, if a parent gets something, these kinds of allergies, where you go into anaphylaxis or, if these severe immune responses to, peanut proteins and that sort of thing, if your parents had it, the kids probably will too. Okay, so treatment, like I said before, all right, we hit it, we talked about this a little bit before, but a little bit more won't hurt. So antihistamines, this is to block the release of the granules in the granulocytes. So your eosinophils, your basophils, your mast cells. Okay? Antihistamines, but it's not going to be enough for anaphylaxis. What this is going to do is, well, if without the granules being released, you're not going to have the vasodilation. You're not going to have all the soldiers rushing to that area. You're not going to have the redness, the swelling, and the mucus production. So it's going to reduce that. One of the things you probably know is to try to take your antihistamines before the allergen appears. So if you know you're going over to your sister's house and she has cats, the day before, maybe take an antihistamine. So because yeah, once once you get the cat dander attaching to your IgEs that are attached to the mast cells, okay, that triggering, I mean, once this trigger occurs, the chemicals will be in the body and you'll get an inflammatory response. So you basically want to get the antihistamines to the granulocytes before you come in contact with the allergen. Make sense? All right. Um, okay, we talked about corticosteroids. If a patient has severe allergies, asthma, or even an autoimmune disease, then we give something called corticosteroids. So what that's going to do is it's going to relax the smooth muscles so you don't get that constriction in the airways. Okay. It's going to reduce inflammation. Why? Well, it's going to stop a lot of those cytokines. Remember when we talked about that cytokine storm? Not really? Okay. All right. Think way back when you have your white blood cells all communicating. Okay. What do we call those communication signals? Cytokines, right? So this is how the military force kind of talks to one another inside the body. You have too many cytokines, you're going to have a big battle to a huge war. Okay. So, corticosteroids will stop the release of all of those chemical signals. And remember, the chemical signals are going to your eosinophils and your T lymphocytes and mast cells and macrophages and dendritic cells. And it'll even help with all of these cells, including the smooth muscle cells. So, and stop the goblet cells from secreting mucus. So that's all really good. So a lot of times you have to use corticosteroids as a strong anti-inflammatory. However, look at all the stuff that's blocked. Remember from last week? What are you going to have left? Not a lot. You are going to be very you're going to be immunologically incompetent. Okay? You're going to be immunosuppressed. So it's important to breathe when you need corticosteroids. You need corticosteroids. But long term, this is not good because your patient will be prone to so many infectious diseases. All right. So this is not a good long-term solution. So just so you know, and just FYI, corticosteroids suppress phosphodiesterase, that enzyme. Okay. So what can we do? Now, some people, if they have an allergy, they can go in for desensitization. And that's what we saw, no, I guess I didn't show that yet. So, okay, desensitization. Have you heard of this therapy? Like, okay, I'm allergic to peanut protein, so you're going to inject peanut proteins into me? Is that crazy or what? How is that going to work? Well, so here's how this works. So this is one treatment to prevent allergic reactions. We weren't quite sure how this worked. We hypothesized what was going on, and now we're pretty sure that this is what's going on. When you get immunotherapy, it will alter your immune response by desensitizing the immune response. So how are you going to do that again with the peanut proteins? Well, if you can inject the peanut proteins into the tissue where the B lymphocytes will make IgG antibodies. Okay? So if you can tell the immune system, we need to make a lot of IgG antibodies against peanut proteins. Okay, we're not gonna do this to the mucosal areas, just maybe like here in the arm, where the reaction, the humoral response would be to make IgG antibodies. So we're gonna make a lot of IgG antibodies against peanut proteins. How is that gonna work? Well, the IgG antibody can go in and bind up all of the peanut proteins once it gets in. If you have a lot of IgG antibodies in the serum, high serum titer, then the IgG antibodies will find all the peanuts and clump them together, the peanut proteins, and they'll never get near the IgEs that are attached to the granulocytes. So to do this, you have to inject really, really diluted antigens, very, very small amounts over very long periods of time. But it really has some good success. You have to be careful. You are giving this patient low doses of antigens, but it can still put this patient into anaphylaxis. So generally, they have to stick around the clinic for, well, again, the worst reactions are usually within the first 30 minutes. So they're not going anywhere for at least 30 minutes. They have to sit tight, and there's always an EpiPen nearby so the nurse can grab that. Again, we think the IgG is going to grab all the peanut protein so the IgE doesn't. So no free IgE means the mast cells don't degranulate. And here's a very good example. So here we have waiting after we've been sensitized against peanut proteins, or, oh, sorry, in this case, cat dander. Let's say you've been sensitized before. So you've made all the IgE antibodies that would attach to the cat dander. And if the cat dander made it through and attached to these antibodies, then that would cause the degranulation and you'd have all of those allergy symptoms. But if you were exposed to immunotherapy and and because of that you have a whole bunch of IgG antibodies. So these are the IgG antibodies, and they have attached to all the kitty dander proteins. So that means the kitty dander proteins don't get over here. See that? So they're blocking it, they're binding it, so it doesn't get to the IgE. This is how it works, which is kind of cool, isn't it? So yeah, you have your sensitization, the IgE attaches to the granulocyte, it's all ready to go. They're sitting there waiting for the next cat dander to show up. And the next time around, though, if the IgG antibodies are there, they will bind up the cat dander, so you don't get degranulation, you don't get the allergy attack. Yay! Now, there's other things that you can do to treat certain problems. You can make preformed antibodies that can actually work in very interesting ways as therapeutic agents. So sometimes patients are given a new drug and you wonder, what is this drug? And you're not quite sure. And sometimes they end in MAB. That stands for monoclonal antibodies. So the patient is getting antibodies. Why? Well, remember, antibodies are very specific, like heat-seeking missiles. They go after one thing and one thing only. Okay, so what could we do with that? So, okay, you can actually make antibodies to go after the other antibodies. So you can make not only, with the desensitization therapy, you can give somebody preformed antibodies, and that will clump up all the IgEs before they have a chance to get over and attach to the granulocyte. You don't need to know the name of this particular drug, but it ends in MAB. So whenever you see AB, you think antibody. It's not a chemical like a poison. No, no. These are antibodies. They're using something preformed, pre-made. Okay. This is how monoclonal antibodies are made. You don't need to know this very in much detail, but they take cancer cells actually, and they fuse them with, and the cancer cells are myeloma cells, the B cell line that are cancerous myeloma cells, and they fuse them with regular B cells that make a particular antibody. So you get these cancer cells, but they're not going to be cancerous. What they do, though, is they replicate indefinitely and they make tons and tons of antibodies. Now, because these antibodies are very specific, we can make antibodies that attach to, ooh, just about anything. Maybe a marker on a tumor cell. And we can attach a radioactive little chemical to it, or some kind of toxin, or something like that, and release this into a patient, and it will bypass every other cell, but it will attach to tumor cells. It's very clever therapy. So on a test, just know if I say, okay, what is this drug that ends in MAB? You would say, well, these are preformed monoclonal antibodies. and these are used in therapy. Okay, here are some examples. Some other examples of where antibodies are used in therapy. Have you heard of gamma globulin? Somebody gets a needle stick, they've been exposed to rabies, and they get gamma globulin. Well, what is that? Is that a poison? No. Is it an antiviral? No, 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 no. What this is these are preformed antibodies. So gamma globulin is also immune globulin, usually IgGs, usually. And they would be antibodies against something specific, like, oh, I don't know, antibodies against rabies. Okay. So we give these to patients to stop immediate threats because the patient slash host can't get the job done fast enough. They can't make their own antibodies fast enough because it takes several weeks and you don't want to mess around. So, but when you inject, okay, these preformed antibodies, so these would be antibodies against and that would attach to rabies viruses actually and neutralize them so they can't hurt the patient. Now, this isn't permanent. This is just temporary. It's a temporary fix. This does not mean you get some kind of memory. It's not a vaccine. These are preformed antibodies, so you didn't make them. They're temporary. Here's some others. Here is an immune globulin against the tetanus toxin, which will kill you very quickly. If you're not making your own antibodies, you're going to die. So they many times give you an immune globulin with anti-tetanus toxin antibodies to neutralize the tetanus toxin. They do this a lot also with botulism toxin and several others, Clostridium perfringens as well. So here we have if you needed antibodies against polio viruses, but again, we don't have to worry about it. And this would have, again, a different kind of antibody. So notice they all have, again, different types of variable regions. Okay, they would all neutralize different things. Okay, so I'm going to quickly go through type 2, 3, and 4. Type 2, hypersensitivity. Remember, A for allergy, C for cytotoxic acid. So this response destroys cells. It's cytotoxic hypersensitivity. It does involve antibodies as well. The antibodies will react with molecules, though, on a cell surface. And because of that, it's going to trigger the destruction of cells. Two ways that it does that through the complement system. It actually will put that membrane attack complex and attach it to one of your cells and kablooey, blowing up your cells. This can happen because the natural killer cells start releasing perforin and granzymes, poo, blowing up your cells. And golly, if this happens in blood vessels, this could produce debris, block blood vessels, start clotting. You could get kidney damage as well as fever, respiratory, digestive problems. It can be life threatening, which is why we need to be sure that we don't give the wrong blood group when giving a transfusion, because mixed up ABO blood types will do this and cause hemolytic disease, especially in a newborn. There's also, well, of course, when the fetus is Rh positive, that means they have an antigen on their blood cells. Mom's Rh negative, she doesn't have it. So when she is sensitized the first time with the first baby, she gets memory. But then if the second baby is also Rh positive, she doesn't recognize the positive and she thinks that's non-self. So, her immune system would go after the baby, which is why you have to give preformed antibodies, anti-ROGAM, right? Which is Rh antibodies, and that will bind to any Rh blood cells that have entered her circulation. That's kind of nice. Okay. So again, this is ABO hemolytic disease. By the way, incompatibility occurs in about 20 to 25% of pregnancies. And and hemolytic disease only occurs about 1 in 10 such infants. So you can look at this. I'm not really going to spend any time on this. I don't have time. How about type 3? This is going to be, okay, so ACI acid immune complexes. This just means IgG and IgM antibodies started to attach and form big clumps of antibody antigen complexes. And can you imagine if that occurs in your joints or blood vessels? Yeah, it can actually trigger blood clotting. Okay, so this can happen because you've been exposed to pathogens, but also because of dust. So, and by the way, penicillin, a severe penicillin reaction will do this. I just wanted to show you this is a really bad case. This is disseminated intravascular coagulation, DIC. This can occur because, again, you've formed immune complexes. So you can get rashes, joint pains, pretty bad stuff. We'll talk about farmer's lung a little bit later on. I just don't have time, you guys. Sorry. So type 4, this has nothing to do with antibodies. This is all the cytotoxic T cells and sometimes natural killer cells going after your tissue. So this can occur anywhere in the body. The peak is usually 2 to 3 days following an antigen exposure. But actually, this is what happens when you get a tuberculin skin test. So you get the little pieces of Mycobacterium tuberculosis, the bacterium, and it's injected in the skin, and you get kind of a thickening and a reddening. More on that a little bit later on. I just can't spend any time on it. Okay, and of course you can get dermatitis because you can form basic your T cells in your tissue, your cytotoxic T cells and your natural killer cells don't like the bad jewelry you're wearing. So nickel jewelry and a lot of other things will cause contact hypersensitivity or contact dermatitis. So this would be me. Okay. And this is just showing more and more of what happens. So again, it's not an antibody thing. It's the T cells are going after your tissue, and you're having a big battle. Cytotoxic T cells with perforin and granzymes, and yeah, pretty bad. And this just shows you can get some really bad blistering. Here's the helper T cell that just freaks out. It gets exposed to something like nickel in your jewelry, and the dendritic cell says, "Here, T cell, you need to respond to that." And the T cell says, "Fine, I'll tell the cytotoxic T cell to go and blow up, attached to the cells here, and blow up." And this is what you get. So, yikes. All right, how about some questions? When your immune system responds to something harmless in the environment and actually causes harm, this is an immunodeficiency, immunocompetence, point of irreversibility, desensitization, sensitivity. Of course, E, hypersensitivity. Okay, so autoimmunity. This is sort of your body saying, "Hey, you got the wrong guy." So this is something that isn't even foreign. This is self. An autoimmune disease means that, okay, you're not overreacting to some foreign particle and thinking that it's bad when it's not. This is you reacting to you. You look weird. So you look for some odd reason like non-self. And there's a whole range of autoimmune diseases. By the way, ladies, you are 3 times more likely to have an autoimmune disease. Yeah, congratulations. I know, me too. I hate it. So, in fact, you're more likely to get most immuno problems. So, okay. So, as far as these autoimmune diseases, they can be organ specific. So, it can attack one organ like your pancreas or go systemic. Which is bad. Okay, damage results from antibodies and or cell-mediated immune responses. So again, it's looking at your own cells going, let's attack. So in type 1 diabetes mellitus, this is organ specific. For whatever reason, your body thinks that the beta cells, the pancreas, are non-self. Okay? And your cytotoxic T cells go after it. Now, remember, the beta cells of your pancreas are the ones that produce insulin. Not good. So if these cells aren't around, you're not making insulin, and your cells of your body are no longer going to properly take up glucose. Remember, the insulin is like the key. It has to go into the lock before the cell takes in the glucose. So here we have an example of Graves' disease, and this gentleman has an inflammatory response, basically called a goiter. The antibodies are attacking receptors on the thyroid, and the thyroid, because it makes thyroid stimulating hormone, you get an increased activity actually. Okay, so lots and lots of hormone production and gland enlargement. And again, you can get the goiter. You don't need to know Graves' disease, but this is just one of those things. Do you know this actor? This is Marty Feldman. And yes, this is from Young Frankenstein, which is one of my favorite childhood memories. But Marty Feldman kind of had the bulging eyeballs. So he had Graves' disease. He had an overactive thyroid, too much hormone because, again, they were attacking the receptors. So the inflammatory response was looking at cell receptors here and thinking, whatever this is, it's non-self. So bad. Okay, another autoimmune disease. Now, this one you need to know. This is there's two of them you need to know. Systemic lupus erythematosus, also known as lupus. Some use the abbreviation SLE. This is systemic. Why? Okay, imagine, if you will, that you had an immune response against your own nuclei. Now, this young lady, okay, she's full of cells, and most of those cells have nuclei. So imagine getting a humoral response, making antibodies, and they're all labeling these cells for destruction, the cell nuclei. So this is going to be systemic, and she's probably going to suffer from severe joint pain, swelling all around in the joints, rashes, but one of the classic rashes is the butterfly rash here. Okay. Something else, my mother suffered from this, and it is in my family. So far, I'm okay. But rheumatoid arthritis is another example of an autoimmune disease, and it is systemic. Basically, it thinks the connective tissue is bad, foreign, and especially, again, in the joints, which is why you see swollen joints. The T cells and antibodies target all of this tissue. You get swelling. Just think of a constant battle going on all the time in your joints. And again, it can cause paralysis. So you can't use your hands, and it's very painful. Okay, this is another one which is very important. This is Guillain-Barré syndrome. Raise your hand if you've had a patient who's had Guillain-Barré. Somebody? Okay, well, what happens? The patient will come in and they might have anywhere from mild to severe paralysis. Okay, like this gentleman here. So what happens is the immune response goes after the myelin sheath that insulates your nerves. Nerves are kind of important. Okay. So, yeah, what happens if you don't have a myelin sheath for insulation? Well, okay, you're not going to get impulses, you're going to have paralysis. This is triggered by infectious organisms. So, like this gentleman may have suffered from some viral or bacterial infection. The immune system went after the bacteria and viruses and took them out, took care of them. But some viruses and bacteria will confuse the immune response. Some bacteria will look and have ID tags like what are on the surface of the myelin sheath. Or also some viruses will get into side cells, and those cells will start looking like, ooh, the myelin sheath. So you get an infection, but it's gone, but the immune system gets confused. So, what kinds of organisms trigger these? Well, we know of a lot of them. Something called Campylobacter jejuni, very common if you consume unpasteurized foods. People who work in dairies and farms with cows and other animals get this. Sometimes it's just a GI infection, but it goes away, and the next thing you know, there's paralysis. Some of the herpes viruses, there's a lot of different kinds. There's herpes simplex, chickenpox, mono. Yeah, influenza. Something that sounds like influenza, which is Haemophilus influenza or H flu. Lots of others. Now, If the real infectious agent can trigger Guillain-Barré, could a vaccine that contains those bits and pieces or whole organisms trigger Guillain-Barré? Yeah, unfortunately. 1 in 100,000 recipients might have some effect. Again, anywhere from mild to severe. Okay. This tends to be more of a type 4 hypersensitivity, but I'm still putting it in here. Okay. So again, this is not really antibody motivated. This is your cytotoxic T lymphocytes going after the myelin sheath. So look, so the neuron's trying to send out signals, not working. Like on the right hand side, it's working. On the left hand side, it is. So, okay, you're not going to have any muscle action. So when your patients come in with Guillain-Barré, you're going to have to tell them, or you should be able to explain to them, okay, you had some infectious organism in your past. It went away, but your immune system got confused and thinks it's still fighting it. And that's what's going on. So I've met a couple people who have had this. Okay, and one was a young gentleman. He was about 24 when he got it, and he always had to walk with a cane afterwards. We think this happens again because of molecular mimicry. You don't need to know these terms, but again, we think that there are little ID tags on the outside of some of these organisms that look like the myelin sheath. Okay, that's what we think. Okay, by the way, multiple sclerosis is a lot like this, and if you have somebody with MS, there's a new drug that has just supposedly been approved, so look into this. You might be interested. I'm not going to have time. Immunodeficiency. This is when the body is yelling, "Help! Is there anybody out there? Can anybody respond to this?" So immunodeficiency, as the name implies, this is a lack of sufficient responses to something non-self. There are two ways to do this. There's the primary type of immunodeficiency. You're born with it, so it's congenital. Results from a genetic defect, or it could be also an environmental factor that impaired development. We think that might be it too. Second is you acquired it throughout your life, and it occurs as a result of infection or some other stresses on the symptom or on the system, excuse me. And this could be like malnutrition can cause immunodeficiencies. Stress can cause immunodeficiencies. If you had influenza, that can cause immunodeficiencies. And of course, if you have HIV, that definitely causes immunodeficiency. So all of those are secondary acquired, okay? So here's the worst case scenario, and there are many cases that are not this far, not this advanced, but what would happen if someone couldn't make good B and T cells, no humoral or cell-mediated immune response? Okay, think of all the things you couldn't take out. You couldn't take intracellular pathogens, right? Because without your cytotoxic T cells, yeah, they're not going to work. So you can't take care of intracellular pathogens or cancer either, for that matter. You can't go after extracellular things very well either. So all the bacteria and viruses that are free floating, yeah, wouldn't be able to do it. And you sure wouldn't be able to make memory because you don't have your T cells. So this is severe combined immunodeficiency, or SID, also known as bubble boy syndrome, which is so tragic. And there are some people who cannot make good B cell responses, some can't make good T cell responses, some can't make good complement, some can't make natural killer cells. So there are many different intermediates that we just don't have time for. So, like I said, there are a lot of exposures throughout your life that can cause secondary immunodeficiency disorders. So, let's talk about viral infections that can do this. Measles. Thank goodness we have a measles, mumps, and rubella vaccine, but measles will replicate in lymphoid cells and destroy them. Okay. In addition to measles, and you don't need to know the following, but syphilis, leprosy, malaria, all are going to impact T cell populations and macrophage functions. So T cell mediated, right? Okay. So intracellular parasites, memory cells, that sort of thing. And macrophages, your garbage men aren't going to be working. They're going to be on strike. So that's not good. Okay. So HIV, we already know that. It destroys your helper T cell, your CD4s. So what are you going to do? Yeah, what do you have left? Well, okay, you have your B cell humoral line, but you can never make memory. And you can't go after intracellular bacteria, intracellular viruses, nor can you go after cancer. Okay? Okay, I want to address a few things. Therapy. So, how about an immune booster? Really? So you see this, you should ask, really what kind? What if I have some hypersensitivity? What are what if I'm responding and I have an autoimmune disease? I don't want to boost anything. Okay, probably not. So, yeah, you better tell me what kind you're boosting my immune system. And again, what kind, even if it worked, do I want this? So little side note about this one, created by a school teacher, which cracks me up. She's never so wonder how many immunology classes she had while going and learning her K through 12 curriculum. But okay, just so you know, Airborne just lost a big lawsuit, 23.3 million. You should know that Airborne's creator is Victoria Knight McDowell, and she is a school teacher, and her husband, Ryder McDowell, and he's the script writer. So who else to push this? So instead of hiding their lack of credentials, they boast about them on their webpage. So yeah, I don't think so. How about this? And pay attention here. How about an immune modulator? Keep your balance. Keep stress levels down. High stress levels will really mess up your immune system. Okay? So what you don't want more of a particular response. You want the responses that you have to work properly, to respond properly. Do you remember the handshake and the chemical signals, right? That go on. You have your dendritic cell talking to a helper T cell, which then might have to talk to a B cell. Everybody has specific receptors. They're doing their handshake. They're having a specific cytokine conversation. So we want them to work well. We want an immune modulator. What would that be? Okay, so maybe you're not into yoga and meditation. If not, try vitamin D3. Vitamin D3 is amazing. If you look on, there's lots of blogs. You would think that vitamin D3 would give you world peace. Wouldn't that be nice? But here is an article if you want to read this. So D's the vitamin, and get D3. D3 is the bioavailable one. Don't just get D. Okay. But it regulates your T cells. Oh, yeah, intracellular parasites, cancer, viruses, and oh, yeah, tells the B cells to be more efficient and make memory. Okay, so where do we normally get vitamin D3? Or at least vitamin D. Do you remember? Nutrition? Sunlight. Yeah, yeah. So people normally get their vitamin Ds from sunlight. Okay. And we know vitamin D is a direct and indirect regulator of T cells. We know this. You can look it up. You can click on the link. By the way, here is a map that shows the global distribution of multiple sclerosis, a very nasty neurodegenerative disease. Again, attributable to probably an autoimmune disease. So looky here, high risk right here. By the way, the equator is right here where you get the most sunlight. Okay. So, And by the way, in the United States, where do you think the highest number of cases will be found for multiple sclerosis and autoimmunity and other immune problems? Right here, Pacific Northwest. Okay, Pacific Northwest, which is Okay, like Oregon, right? All those clouds and rain. Yeah, high cases of MS there. By the way, we could look at, again, a lot of immunodeficiencies and autoimmune diseases, same thing. And there's definitely some kind of trend going on here. So if you're getting enough sunlight, we tend not to see these autoimmune diseases. So that's why they push the D3, everybody. Okay, how else can you modulate your immune system? How about tryptophan and niacin? Tryptophan, I heard of that in nutrition. Oh, yeah, tryptophan comes from turkey. Yeah, Turkey Day coming up. Niacin, vitamin B, one of the vitamin Bs, one of the good ones. Very good T and B cell modulators. Very good. By the way, so if you go out and get tryptophan, get the L-tryptophan, and also take it at night because it will put you to sleep. It'll make you sleepy. Little side note, too, by the way. Don't take vitamin D late at night because it makes you awake, almost like sunlight makes you awake. So take your vitamin Ds throughout the day, maybe morning and afternoon, early afternoon at the latest, but not at night. Take your tryptophan at night. Okay. Tryptophan also helps you make serotonin. You know, the happy neurotransmitter. Yeah. So serotonin. So yay. So tryptophan is a win-win. Be careful though, too much tryptophan might mess up your normal microbiota in your gut. So be careful of how much you take. Okay. So just summing up, why do the bacteria make it and survive and cause disease and make us sick? What do they, and sometimes people don't get sick. So, between pathogens and hosts, it's all about, again, genetics, it's about nutrition, and also numbers. Okay, numbers. So when it comes to the pathogens, how many soldiers are coming in? What weapons are they packing? Well, that's going to have to do with genes. They could be carrying other virulence factors, again, genetically virulent, making toxins, that sort of thing. If they're fed well, and by the way, a lot of pathogens like to steal your iron. But anyway, if they're well fed, then they're going to have a good old time of it. So, what keeps them out? Your barriers? Is your skin intact? Hopefully so. What about your numbers? Well, that would be your soldiers and weapons. The weapons are chemical weapons that have to be manufactured in the immune cells. So, are your immune cells made well? Are the chemical weapons made well? That all depends on your genes, right? Okay. And you want to feed them. You want well-fed, happy, healthy cells, your white blood cell soldiers. Get them enough oxygen, exercise, that sort of thing. Then they can make ATP. You want vitamins, good amino acids, and iron. So let's just summarize all the factors influencing your susceptibility to diseases. So immunocompetence, genetic constitution. There are just some people who get sick all the time and some people who never get sick. The result of your general health, nutrition, age, and behavior. Okay, so it's like everything else. Um, Exercise, eat right, be careful what you expose yourself to. Sadly, age sounds very ageist, but the truth of the matter is, ladies, and this is true for gentlemen too, we lose memory as we age. You're like, yeah, I know, cognitive memory. No, 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 not just cognitive memory. as as everything kind of breaks down, it turns out immunologically we lose memory cells. So we can then get disease where before we were pretty well protected because we had already made memory cells, but the memory goes away. So it's important for older people to get those boosters. Okay. So when it comes to general health, again, get enough iron. By the way, without iron, your T cells drop. So take iron, especially, after the menstrual cycle, after menses, you want to get some iron in there because you don't want your T cells to drop and reduce their function. Of course not. Do not smoke, right? Not only is that going to hurt your cilia that gets everything up, but yeah, the immune cells are all tied up clearing the blood and tar out of your lungs. So your poor dendritic cells. Sun. Now, I know, didn't I just say the sun makes vitamin D? But uh, in moderation, unprotected exposure temporarily depresses T lymphocytes and natural killer cells. So, yeah. So, these are the guys that defend you not only against viruses, but cancer. Hmm. Exercise increases lymphocyte activity. Yay, personal hygiene. Okay, keep it clean. Wipe from front to back. Okay, not only you, but your patient and your children. Okay, so and keep it clean. Reduce, reduce, reduce. Take care of your skin. Occupation. Well, unfortunately, all of you are on the front line, so you tend to be more exposed to pathogens and needle sticks and all kinds of things. So, sex, oh, sorry, laughter shouldn't have come up so soon, but yes, unfortunately, if you are female, we get a lot of problems. We tend not to be as immunocompetent because we have a short urethra, right? We get a lot of bladder infections and other things. Laughter, the evidence isn't in yet, but it can't hurt. There's some evidence that says yes, laughter increases your immunocompetence, and then other studies that say that's not really true. But we do know that stress reduces your immune response. So seems like laughter is the opposite of stress, right? So minimize your stress. Stress causes many hormone changes and causes a lot of illness. But we know that it does, in fact, inhibit B and T and natural killer cell activity. So that's wiping out, your a lot of your second and third immune response. By the way, there was a study done that looked at people under chronic stress, chronic stressful situations. They were actually they looked at, excuse me, not pharmacy students, dental students, and caregivers of people with like Alzheimer's. The people that have to take care of their older parents and spouses, and they were the ones that had the most stress hormones. They found that their vaccine effectiveness was actually reduced 30%. So maybe you shouldn't go get a vaccine when you're under a lot of sustained stress. Okay. So, yay. Maybe, well, if you can help it. Okay. So, what is this about? Why is it that everybody it's like everybody knows somebody with a severe allergy to something, like peanuts. You guys, really, when I was growing up, peanuts were everywhere, even movie theaters. I mean, it was part of our diet. And nut allergies were just unheard of. Most of these things were unheard of. So, why is this? I'm going to address something with you. And by the way, some of this information comes from The Guardian. Why are our little ones they've got all these respiratory tract infections? Now, we used to think it was air pollution, and LA and California had some of the most stringent control measures in place to control air pollution, which was great because pollutants in air can cause cancer and all kinds of other things. But it didn't reduce the number of asthma cases, okay, in the little kids. We just didn't see it decrease, and we thought we would. But then, of course, that's still good. We don't want lung cancer or anything. We want to be able to breathe. We want clean air, but this wasn't addressing it. So what do we think it is? So why do we have increasing rates of allergies and asthma? It just keeps going up. Going to talk to you about the hygiene hypothesis. Now, if you remember, a hypothesis is an educated guess, but it's not somebody just saying, hey, I have an idea. No, by educated, that means it's taking all of the information we have up to till now and doing lots of research, lots of experiments in many different labs, using many different disciplines, not just immunologically, but other disciplines to try to, and sometimes just using public health officials to take statistics. So that's the hygiene hypothesis. So here's what we know. We know that the gut flora in the West has changed in the last few years. Yeah, normal microbiota. Could that have something to do with it? And we know that asthma rates have increased. We do know that there are a lot of pathogens, bacteria, even bacteria related to Helicobacter pylori. Yeah, the one that causes stomach ulcers. We know that that bacterium that we hate, I hate it, Helicobacter, some species secrete an anti-inflammatory substance. For whatever reason, it will stop an allergic and asthmatic reaction. We know that worms, parasitic worms, some of them will suppress an inflammatory response. Okay, so, and it's probably not just a few pathogens, but probably many. And we are, and I have this, yes, I photoshopped this man feeding the chicken pills, antibiotics. But our environment has changed, everyone. It has. So we've kind of gone from this, I love baby goats, little kids. I love all kinds of kids, to kind of something a little bit like this. Okay. This is how I grew up, by the way. More like, no, this isn't me. So could be, got the tummy there and the cheeks, but no, not me. So here we have, again, here's the maps of autoimmune disorders. Okay, things like asthma and that sort of thing. And here's where we have the highest rates. Now, it turns out that these are the cleanest areas. Now, this is a map that shows parasitic worm infestation rates. So now, again, there's just lots of things coming into the puzzle here. This itself isn't, a smoking gun or anything, but it is highly suspicious. But here's the other thing. Do you remember? Now, this is busy. Don't look at it for now. Just listen to me. Do you remember when I told you that IgE antibodies and eosinophils are found when? When there's an allergy. When else? When there's a parasite? Yeah. So, and there's more to it. If we had time to talk about the different kinds of helper T cells and how they interact with dendritic cells, yeah, you would find that there's a lot of coincidences here. And there's a lot of scientists who are promoting the hygiene hypothesis, including Joel Weinstock from Tufts Medical Center in Boston, Massachusetts. And he's an immunologist and he's studying the body's immune response. Okay. And it's not just parasitic worms, but there's a lot of good soil bacteria, including this one, which is really nice, Lactobacillus rhamnosus. By the way, this is in a lot of probiotics. Sweet. Okay. So what am I telling you? Expose your patients to parasites? No. Not at all. Your patients are they're probably immunosuppressed. They're stressed out. No, and it wouldn't work anyway because adults, at least when it comes to adults, they've already trained their immune system or not. So, and again, your patients are probably in crisis when you see them. So, no, 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 not I'm not saying that. But maybe we need to take a look at other things. Okay, and no, we don't want to expose babies to parasites either or pathogens. No, 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 no. We don't want to do that. Maybe consider probiotics. Okay. Maybe rethink how children play. Maybe nature's okay. Go out and play a little bit in the dirt. Go out and play in the country and, play with the animals a little bit. So maybe everybody should get out and enjoy nature a little bit, collect a little soil bacteria in the gut. Okay, maybe it's not a problem. Um, some people are looking at, okay, what are the chemicals that are calming the immune system and are working as immune modulators. So these would be immune modulation chemicals. Could we find those? We're trying. We haven't found them yet. Um, so yeah, we're working on all of this. Okay, so this is the hygiene hypothesis. If you want to look into this, you should also, there's a really freaky case study. If we had, well, maybe I'll post it. There are people out there that have given themselves hookworms on purpose because they couldn't breathe. The asthma was so bad they couldn't breathe. So they gave themselves parasitic worms called hookworms. And let me tell you, hookworms of the parasitic worms are nasty, but it worked for them. I don't know. I like breathing, but I don't like parasitic worms. So, and I could not possibly expose this little thing to something like that. So, okay, let's ask some questions. Stress reduces which of the following cells responsible for immune responses? T cells, B cells, natural killer cells, all of the above. You bet, all of the above. D. What is the hygiene hypothesis? A. Diseases caused by germs. B. The reduction of allergens at a young age will prevent asthma later in life. C. By removing germs from the environment, we may have unintentionally produced autoimmune and allergic diseases. D. By providing global immunizations, we can eradicate disease. E. By avoiding immunizations, many children avoid autoimmune diseases. And okay, disease is caused by germs is the germ theory. But okay, C, by removing germs from the environment, we have unintentionally produced autoimmune and allergic reactions, and that is the hygiene hypothesis. What is Guillain-Barré syndrome? A, an autoimmune response. B, an allergic response to pollen. C, an active bacterial infection. D, an active viral infection. E, parasitic worm larvae forming cysts in the brain. Okay, there is a condition where parasitic worm larvae do form cysts in the brain, but Guillain-Barré is an autoimmune response, and there's no active pathogen infection. There's no bacteria or viruses anymore, or probably not. Immune disorders. Immune system disorders are caused by A, genetics, B, environmental triggers, and C, all of the above. C, all of the above. So to help things out, maybe you take immune modulators, vitamin D, tryptophan, okay, your vitamin sixes. Okay. Rituximab is a drug sold under the brand name Rituxan. It's used to treat certain autoimmune diseases and types of cancer. Just looking at the name, what is the main characteristic of this drug? A chemical that targets a structure in a bacterial cell wall. B, a chemical that stimulates an immune response. C, a drug that produces the production of cytokines such as interferon. D, preformed monoclonal antibodies. E, something that produces memory cells without disease. Of course, that's D, preformed monoclonal antibodies. Remember, I said you don't have to know the drug names, but if you see MOB there, you should know these are antibodies, little heat-seeking missiles. You can attach all kinds of chemicals to it, like radioactive chemicals, anything to take out tumors, okay, and cancer cells. And something that produces memory cells without disease, what is that? Yes, a vaccine. Good. When your immune system responds to something harmless in an environment and actually causes harm, what was that? Hypersensitivity. Good. Okay. The patient is diagnosed with type 1 diabetes mellitus. What is the cause of this? A, an immunodeficiency. B, autoimmunity. C, bacterial infection. D, viral infection. E, hypersensitivity. Okay, so again, it's not an immunodeficiency. Probably it's more of an autoimmunity, so it's B. Okay, we would consider this a B. Okay. Your patient has joint pain and a butterfly rash. Excuse me. Your patient has joint pain and a butterfly rash on the face. The doctor doesn't prescribe an antibiotic because they probably have what? Rheumatoid arthritis, type 1 diabetes mellitus, systemic lupus erythematosus, severe combined immunodeficiency, a viral infection. Well, of course, you would not treat with an antibiotic for any of these, but this person has systemic lupus erythematosus, which again is just the body going after the nuclei in the body. Antibodies are being made against the nuclei of the body, and you form these immune complexes, which are pretty bad. Okay, so now we're going to talk about various kinds of infectious diseases. So this is the grab bag of infectious diseases. And what I don't complete this week, of course, I will complete next week. And it breaks my heart. There are just so many things that I'd like to talk about, but there's just no time. So I'm going to give you the best hits of, I think. But hopefully after this class, you have enough information that will allow you to look things up. You have that ability. Yes, you do. And hopefully you have the foundation now to understand why antibiotics work on some things, not others. Like there are some antibiotics that work on some bacteria, but not all. The antibiotics are not going to work on the viruses, and some of the antivirals will not work on every kind of viral agent. So, yeah, and we're also going to introduce some eukaryotic pathogens, so fungal organisms, and maybe a little bit more. Okay, so here we go. We're going to start with, we're going to go through the integumentary and respiratory symptoms. This is, if you're wondering what this is smallpox. This is a good illustration to show you that now smallpox is transmitted through the respiratory tract, but clearly it causes lesions on the skin. I'm not going to do a spiel on smallpox because you're not going to be seeing it. But still, this is just to let you know that we're going to talk about skin diseases and respiratory diseases, but also know that they overlap, and a lot of these organisms that I'm going to talk about cause a lot of different problems. So just bear with me. You have to sort of put them in some kind of category. So that's what we're doing. So stay tuned. Microbes, health, and disease. Just a quick summary before we get into the little agents. Keep in mind most microorganisms are completely harmless, and we're in contact with numerous microorganisms daily, and they're not going to harm us. Some of them colonize our body surfaces, others shed with dead epithelial cells. Many are so beneficial. Remember our normal microbiota. Yes, they help to keep us immunocompetent. Yes. Okay. So they help us to produce a whole normal immune response. They not only will fight off the bad guys, but one thing I didn't mention is that they will train your immune system, as it turns out. Okay, now some microorganisms we do come in contact, of course, are pathogenic, or maybe they're potential pathogens. We will even find that some of the normal microbiota can turn on us. So, sorry, hope I didn't startle you. All right, so let's talk about pathogenicity. There are sometimes these organisms that we call the primary pathogen. It's the microbe or virus that causes disease in an otherwise healthy individual. Primary pathogens include the plague, malaria, measles, influenza, diphtheria, tetanus, tuberculosis. And with these guys, for the most part, if you come in contact with these things and you don't have any kind of memory cells against them, you're probably going to get sick. But there are also opportunistic pathogens that I want to talk about. These guys, so they're opportunistic. They cause disease only when the body's innate or adaptive defenses are not working, when you're compromised, immunocompromised, or maybe when introduced into an unusual location. That can happen too. Like they don't belong there. E. coli in the gut is okay. We don't want that inserted deep into a other body cavity. Again, opportunistic pathogens sometimes can be members of the normal microbiota, or maybe they're common in the environment, not causing trouble to most people. But if you have somebody on chemotherapy, somebody who has diabetes, somebody with HIV, okay, these are going to be problems. So we're going to talk about Candida albicans that causes yeast infections, Pseudomonas. I hope to talk about that. I don't know if I can. So you don't need to know these right away, but I did want to again differentiate between pathogen as something that generates disease. You can have a primary or an opportunistic pathogen. Virulence refers to the degree of pathogenicity. So just when I use those terms, I want you to know what I'm talking about. And again, virulence factors allows microorganisms to cause disease. So if a bacterial cell has a virulence factor, it's probably because it has a gene. Okay. Keep their numbers down. Reduce, reduce, reduce. Wash your hands. Soap with water. I can't stress this to any of my students enough. There's a lot of things about this little quick class that you're going to forget. Please, 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 of all the things you forget, do not forget to wash your hands regularly with soap and water. Okay. So, some terms when it comes to the course of infectious diseases. When you become exposed to a pathogen, there is, and that means it's going to generate disease. There's an incubation period. That's the time between you get the infection and the onset of symptoms. How long varies, okay? It can be anywhere from a few days for the common cold or years for hepatitis. It all is going to depend on the growth rate, how fast the organism replicates. The host might be in bad shape and it may take over quickly. Also, the infectious dose, how much do you get? I will talk about that in a little bit. There's another phase called the prodromal phase. This means that this is when it's coming on a little bit. You have vague symptoms. Illness, okay, you've got signs, you've got symptoms. So there are signs like, kind of fast heart rate, something like that going on. You've got a lot of white blood cells in your blood draw and or symptoms. You're sniffly, sneezy, coughing, got a rash, something like that. Convalescence or convalescent. This means you're in the recuperation stage, recovering from the disease. One thing I want to mention, and that's why poor Typhoid Mary is here. Typhoid Mary had Salmonella typhus. She didn't know she was a carrier. She always felt perfectly healthy and was a personal chef to many people, and her specialty was kind of a peach cobbler. And people in that were eating her food enjoyed it until they started to get violently ill and some died. And she couldn't understand, and there's a lot of serious ethical problems with the treatment of Typhoid Mary. She was Irish, she was female, and they treated her very badly. And she thought that she was that she couldn't possibly be causing the deaths of these people that she cooked for because she was perfectly fine. She didn't have any symptoms. So carriers may harbor and spread agents for years without signs or symptoms, and that's what Typhoid Mary did. By the way, you too could very easily be a carrier. Most respiratory infectious organisms are contagious about 24 hours before the first real symptoms appear. So, what does that mean? You always cough and sneeze into your sleeve. You wear personal protective equipment. You wash your hands with soap and water whenever you're around your patients, okay? Especially the little ones. Okay, so let's talk about some terms here that I'm going to talk about. Some people will get a pathogen, an infection, and the body's inflammatory response is able to localize it. So we call that a localized infection. So, and sometimes they stay localized for a while and then sometimes they break away. But a localized infection is a microbe limited to a small area. So, for example, if we look down here, we have boils, okay, created by good old Staphylococcus aureus. So, just down here, okay. Now, what happens if you squeeze that boil? Like a lot of people do. Understand the keratin layer, that these proteins are tougher than the connective tissue underneath. And what'll happen is a lot of pus will get into the bloodstream. And oh, you can get something like this. So you can get a systemic infection. That means the agent is spreading throughout the body. So not just with Staphylococcus aureus, but measles go systemic very easily. So whenever you see the emia suffix, that means that it's in the blood. So bacteremia, bacteria in the blood. Now, this means that the bacteria are there, they're not necessarily going to set up a disease. A lot of people squeeze a boil and they don't end up like this. So you squeeze a boil, the bacteria is in the bloodstream, but okay, no disease. So you can have bacteremia without disease. By the way, vigorous toothbrushing gives you a lot of bacteremia. Bacteria are just streaming through the bloodstream when you brush your teeth. Toxemia, that means toxins are circulating in the bloodstream. Now, that's probably not good. Viremia, viruses circulating in the bloodstream. Sepsis. Now, this means that this is an acute, life-threatening inflammatory response caused by an infectious agent or agents or any kind of products in the bloodstream. So back up to Staphylococcus aureus, and it is clearly there's bacteremia, and now we have septicemia, cellulitis, and the bacteria are releasing their exotoxins, and you're getting a terrible inflammatory response. And yeah, so here's a huge battle. And of course, you draw the borderline so it can't travel beyond that. There will be more information about Staphylococcus aureus later. I wasn't sure whether to talk about them in the skin or in the GI tract. I think I'm going to do GI tract, okay? So again, remember the pathogens must overcome your defenses. Keep your barriers healthy, right? Don't smoke, exercise, take care of your skin, eat right, all of that. Reduce, reduce, reduce. Microbe numbers must be sufficient to overcome the defenses. So they have big numbers. There's something called the ID50. This is the infectious dose 50. This is the number of microbes it takes to demonstrate infection in 50% of inoculated test organisms. So if I took all of you and divided you in half, and I gave half of you a culture to drink of 10 to the eighth power bacteria. And well, let's just say, no, let's say I gave all of you 10 to the eighth bacteria, sorry. And 50% of you got sick, then that is the ID50. So 50% of you got sick when I, gave out 10 to the eighth power bacteria. So this is what happens with Vibrio cholera. They do most of these tests in laboratory animals, of course. So in the human population, they know that if a population drank or consumed 10 to the eighth Vibrio cholera cells, causes cholera, then that will cause disease or infection in 50% of that population. So that's the ID50, 10 to the eighth power. Mind you, if you took those antacids, then you don't need as many bacteria to get through. Remember, the stomach acids take a lot out. There's also the LD50. This is the virulence of the microbe or potency of the toxin, basically a lethal dose for 50% of the host. So if I gave the population a certain amount, it could be a toxin like botulism toxin and it killed 50%. That is the LD50. Okay, the number of microbes it takes to kill 50% of the inoculated test organisms. No, they don't do this in people. Just know if large numbers gain entry, the stage is probably set for disease. So there's a point where you just don't even, I mean, if you consume a lot of bacteria or organisms or toxins, you're going to get sick. Don't even bother counting. Okay, this is something else, point of irreversibility. This is the point beyond which most appropriate treatment has no impact on serious infections. This means probably you went septic. Okay, the viruses causing septicemia, bacteria causing septicemia, the bacterial toxins causing septicemia. Yeah, you won't pull through. Okay, and you'll see that a lot. Okay, so let's talk about some of the infectious diseases. And like I said before, all of these overlap into other categories, but you got to start somewhere. Okay, so here's the integumentary. I know, don't you just want to do Gucci goo? Or worse yet, do a raspberry. I know, babies are so cute. Okay, so we're going to start off with viruses that impact the skin. Okay, so let's begin with warts. Okay, there's only one thing that causes warts, everybody. Those are the human papillomaviruses. Remember, we talked about those, or HPV. These are viruses, they're not living. You cannot treat these with your antibiotics. In fact, there's no antivirals that are going to work with these guys. Surgical interventions are necessary. So the human papillomavirus, so this is a non-envelope virus, meaning that it's going to hang around on surfaces. It's not going to die anytime soon, so you can pick this up just about anywhere. There are many types, about 40 we think, and they all cause little tumors, little warts, or something like that, okay? They all do this. Transmission very easily. Again, the little viruses have to get to the basal layer of the skin, but if you have a skin abrasion, or it doesn't have to be that severe, oh yeah. And remember, the viruses can be on inanimate objects. We call those fomites. You can touch people. There you go. Syndromes. Most of the infectious diseases that I talk about they produce certain symptoms, and with warts, of course, they're little tumors, maybe cancers. But this is the one time where it's not about inflammation. It's the way the virus actually interacts with the body. They hide, okay, from the immune response. They don't start dividing until they're pushed up to the edge, okay? So they're not detected by our surveillance teams. Okay, so syndromes. It's not about inflammation. The syndromes are basically, to start off with, benign tumors, what we call regular warts. You can have seed warts like this. If it's on your foot, we call them plantar warts because you pound them in and they go deep. So that's the only difference between a seed wart like that and a plantar's wart. So there's also genital warts, of course. Now these are, like I said, these are not pretty by any means. Cosmetically, they're awful. You have to burn these off. It's hard to do. And you have to get underneath the basal layer, so you got to go deep. And if they are forming somewhere around the cervix, it's even harder still. There are different kinds, and they are different types of viruses than the ones that cause these. So these are different. There are the HPVs that cause cancer are different strains. So those viruses infect cells in the cervix, the oral cavity, and in the anus, and will cause cervical cancer, oral cancer, and anal cancer. Diagnosis, okay, again, in women, you got to do a pap smear. So, one of the things, though, of course, we have is Gardasil. So, this is what we have. We have a vaccine that is a vaccine against cancer. Okay, it's not going to work around against the seed wart. Sorry, you got to burn those off. But the ones that cause cancer, those are the ones we're interested in, and we have a vaccine. So, yay. Again, we can just see the change, the cytopathic effects of these cells. And here's a cervix that has gone from infection to invasion and cancer. Okay. So again, these are different HPV types of viruses. They're all HPV, but they're different. Okay, whoa, what is this? Okay, ectoparasites are parasites that feed off of you from the outside. We know you're juicy on the inside, but there are some arthropods. That means you step on them, they go crunch, and they do feed on the body and they can be infectious. So I'm going to talk about those now. First of all, lice. And way back when, they used to have toys named cooties. I don't know if they still do, but what is a cootie exactly? Well, it's lice or a louse. Now, there are many different kinds, okay, but in all, lice are small wingless insects and they do suck blood through the skin. Now, the body lice are really the cooties, and the reason these are important is because they can transmit some really nasty bacterial diseases, including something called trench fever and typhus. Typhus is caused by a bacterial organism called Rickettsia broziii, And rickettsia, that's related actually to the Rocky Mountain spotted fever bacterium, actually. But yes, only body lice transmit this. Head lice do not transmit disease, but head lice are extremely contagious. So you got to pick off the little nits that are on the hair. Those, those are just the intermediate, like little egg casings. You've got to take those off, and you've got to use the shampoos, and you got to clean everything. Because, okay, body lice can transmit bad diseases. Head lice are just a big nuisance. Okay. Mites. Okay, now there are many different kinds of mites. A lot of these live, there's so many, and they live on the outer surfaces of plants and animals. Some of them blow around in the dust. Some can cause allergies, like dust mites, right? And can cause inflammatory responses in the upper respiratory tract. Some can trigger asthma, right? But the mites that are particularly nasty are let's talk about the ones that feed off of us, the exoparasites. So first of all, we have chiggers, which are mite larvae, and they may attach and feed on fluids within the skin cells, and they cause severe itching. Okay. Now, the other type of mite causes a condition called scabies. But again, these are both mites. Okay. This is the worst because scabies will burrow under the skin and lay eggs. And again, it is very contagious, very nasty. And it will cause kind of the red flare going up. And I think this is actually scabies and not a Chigger's reaction. But both will cause inflammation. And scabies is very infectious. So you have to be careful. It's commonly misdiagnosed, which is unfortunate. Okay, say ah. Okay, so we're going to talk about fungal organisms. They're very good at infecting the skin. And the reason is very few fungal species will go deep in the tissue. They tend to like it a little cooler, but not always. Okay, so fungal diseases. Well, here's some bread mold. Oh, no, here's a fungal disease. Okay, there we are. So fungi are eukaryotic. Mostly they are harmless, many are beneficial. Again, we use fungal organisms to make wine and beer, make bread rise. Some of them are part of your normal microbiota, actually, so they're pretty good. But there are a few that are parasites. But interestingly enough, there is not a single fungal organism that is an obligate parasite, meaning it doesn't have to be a parasite. But you're in the wrong place at the wrong time, and then you can get a disease, okay? They're extremely widespread. They're all over the place. The disease through fungal organism, the diseases occur in two ways. So, number one is by mycosis and infection. But fungal organisms also produce toxins, and we call these mycotoxins. So there are two routes that can give you disease through fungi. Okay? So let's talk about mycotoxins. The first mycotoxin is called the ergot alkaloid toxin. Sometimes we call this ergot poisoning. The fungus is Claviceps purpurea, and it causes some very strange behavior. Why? Because the fungus is manufacturing psychotropic agents, basically LSD, you know, um, weird mushrooms, right? Well, some years ago in America's history, there was something called the Salem witch trials, where young women swore that they saw other women dancing naked in the moon with the devil and doing all kinds of weird things. And so, what was going on? Well, here's what we know. During that time, there was a lot of grain that was infected with claviceps purpurea, ergot. Okay. So they harvested the grain for the winter and they ate the bread. And lo and behold, crazy behavior. And that's what we think happened. By the way, cattle can eat this stuff and sometimes they can have strange behavior too. Okay, the next kind of mycotoxin is called the aflatoxin because it comes from something called Aspergillus flavus. And this is what the fungus normally looks like. Again, this is something that cows can eat in the field, and unfortunately, it can get into the meat and dairy products. Now, the cows aren't going to like this much, but if you get a hold of the dairy products, or even directly if you get exposed to aflatoxins, you can get severe vomiting, abdominal pain, possibly jaundice, but this can even put you into a coma and kill you, and this is carcinogenic, meaning it can generate cancer. This is why they condemn buildings that have had a lot of moisture. Fungal organisms love moisture on the body, on wood. And how are you going to know for sure that this is completely cleaned up? You know, I wouldn't trust it. There's remediation that can occur, meaning you can try to get rid of the black mold, but a lot of the black mold can produce mycotoxins, and it's just, I don't know, scary. Okay, so now let's talk about fungal mycosis or fungal diseases. Fungal organisms tend not to like it too warm. As I said, most fungal infections tend to be superficial, but not all of them. They are found everywhere and are very opportunistic. Oh, yes, they will move in when defenses are down. However, there are a few that will go systemic and travel to many places in the body. This is bad because oral treatment probably going to be toxic. Why? Fungal organisms are eukaryotic, and so are you. So, what's your target going to be? What is your poison going to target in their cells that won't target yours? Yeah. So, treatment is usually toxic because they are a lot like us. Now, if you have to put a topical remedy on a fungal infection, not so bad. But just know topical agents, like what we use to treat yeast infections, do not kill. They are fungistatic, meaning it could very easily come back. It's not fungicidal. So when you're thinking about, for a vaginal yeast infection, yeah, you better hope your normal microbiota kind of picks up the act a little bit. Okay. So there are two types of pathogenic fungal types. Actually, there are three, but I'm only going to just tell you the two. The first kind is the yeast kind. They look like this and they bud. And then the second type is mold, and they have a lot of filaments. One thing you should know about mold is the part you see is the part that has a lot of infectious little spores and things like that. The part under the tissue it's going to go kind of deep. This is called vegetative hyphae. Trying to get this to die is pretty hard, especially with the topical, because it will only penetrate just so far, and these go down very deep for molds. Molds tend to look a little fuzzier, but not so much in a human infection. Okay, so let's talk about some different kinds of mycosis. And I like this. It says, I'm afraid it's a severe case of tinea pedis. Here's the nurse or nurse practitioner. You could have just said athlete's foot. Tee hee. Okay, so let's talk about ringworm or tinea. The street name is ringworm. You've heard this term. I know you have. But the clinical term is tinea. So if a physician says, oh, the patient has tinea, then you think, oh, it's a fungal infection. It's ringworm, right? So you use ringworm to communicate with your patient, but tinea to communicate with your colleagues. Now, this is the superficial mycosis. Now, tinea is just the name of the disease, but the organisms are named microsporum and trichophyton and a whole bunch more, and they look a lot like this, but they all cause the condition known as tinea or ringworm. Again, it's mold, by the way. It affects a lot of mammals, dogs, cats, cows, goats, pigs, horses, and guess how I got it? I got it by playing with kittens. Yes, very easily transmitted through contact. Okay, so here we have the classic ringworm structure. So it is not a worm, it is a mold, a fungal mold. So you may or may not see a ring shape, and you might see a crusty, itchy, kind of swollen area. It might be red. It depends. But this is classic ringworm. Okay, if it appears on the head, it's called tinea capitis. scalp region. Sometimes you can use a black light if you want to see, is that really what it is? Is it fungal? What's going on here? You use a black light. In the clinic, we call it a wood lamp, and you'll find that this fungus actually fluoresces, believe it or not. In the groin, it is called tinea cruis, okay? Sometimes when you have an obese patient, they have it sort of like right under the apron, and it's very sore. It's very red and very angry. It causes a very bad inflammatory response. Just think of probably all the granulocytes there. So you have to clean very well and keep it dry. The best way is to clean gently with soap and water and then blow dry it with a blow dryer on kind of cool to medium and keep it dry and then do something topical, but keep it dry. For males, they get it especially around the scrotal area. This is a type of jock itch, although there are several types of funguses, the fungi that cause jock itch. Tinea pedis. Okay, athlete's foot. Yeah, look at the inflammation. Tinea unguum, this is under the nails. And let me tell you, if you go out for a pedicure or manicure, you better be darn sure that they are sterilizing their instruments. Why? Because if you get some of this in the nail, it'll go down into the nail bed, and you will have to take an oral antifungal. And they can't give too much to you at one point because it is toxic. They'll have to watch your liver enzymes. So remember, they are eukaryotic and so are you. So you're going to have to take an oral poison. It's more toxic against them, but it can hurt your liver. Okay? How about the common yeast infection, also known as candidiasis? What's the name of the organism that causes candidiasis? It's Candida albicans. So candidiasis got its name from Candida albicans. So this is what we call a yeast-like infection. If you ever took my micro class, actually we call it a little bit yeast, little bit fungal. It's a dimorphic, but I'm okay with you learning it as a yeast. This is very opportunistic and very, well, it is commonly seen in very young patients, immunosuppressed patients, patients who have taken antibiotics and gotten rid of their normal microbiota. How do you transmit it? It's part of your normal microbiota. They just don't get out of hand because the other guys are there. So they are in your oral cavity, in your anus, in the vaginal area, all around those areas and throughout your skin in many areas. They prefer it moist, but yeah, they're all over. So what happens is yeah, again, they're mixed up with your normal microbiota. Hopefully your normal microbiota is in place and everything is in place to keep them at bay. But if things go out of whack, remember that's dysbiosis, then yes, then you're going to get candidiasis. So, example syndromes of candidiasis, vaginal candidiasis, also known as the vaginal yeast infection. So, women with vaginal candidiasis will get sort of a slick, buttery kind of consistency in a vaginal discharge, and it will smell like alcohol. Why? Because yeast are fermenters. So whether they're making beer and wine, which is a different species, or the one that is giving you a candidiasis, okay? Again, guys can get their version called jock itch. There's also oral candidiasis, common in children, common in patients who are immunosuppressed. So this is oral candidiasis or thrush. Now, again, a lot of patients that haven't developed their immune system yet, like children, or patients who are undergoing chemotherapy or are immunodeficient for whatever reason, will get candidiasis, will get this. Children get it all the time. Okay, and it's different than the pus pockets made in group A strep. So here we have again, this is oral candidiasis, and this is where you would see this in a vaginal yeast infection. So how do we not get this? Well, cleanliness, wiping from front to back, keeping your normal microbiota in health. And when you take an antibiotic, get some probiotics going on there. Okay. I wish I had time for this. If you've ever seen somebody who is lighter skin that has dark blotches or dark skin with white blotches and you wondered what that was, that is actually a superficial mycosis caused by an organism called Malassezia furfur, and the disease is called pityriasis. I know, aren't you glad you didn't have to know this? But it's all cutaneous. It can cause some problems, some more severe problems in some individuals. But interestingly enough, when the fungi grow, they can cause too much of a pigment because they will produce melanin, right? Just like our own melanin. Sometimes they will release a type of acid that that will actually bleach out the skin and cause hypopigmentation. So, FYI only. All right, something else. Okay, so this one crosses the edge. This is something called sporotrichosis. The street name would be rose pickers or rose handlers disease. This one starts out as sort of a superficial, but it can go systemic. The organism's name is Sporothrix which again is why it's called sporotrichosis. I'm only going to have you guys know sporotrichosis. You don't have to know the species name. But again, this is a yeast-like organism, not a mold. Symptoms, well, let's just put it this way. It's called rose handlers because people who get cuts, a lot of times the spores and the molds just are everywhere, and the spores can be on the thorn, and it breaches your first line of defense, your skin. And they start to divide and grow in underneath the tissue. And again, it can be rather localized, but it can, and be just a bump on the hand, but it can grow to produce a very large lesion. So let me show you some pictures. Oh, shucky darn, sorry. So this shows where it's causing a really nasty lesion. It almost looks like the body was trying to wall it off, but it looks like it's escaping. And it will, and it goes systemic, and it goes along the lymph nodes and can cause tracts like this. A lot of fungal organisms will do this. It's just like connect the dots. What is going on here? And it's just in a line. And again, it's along the lymphatic system, along the lymph nodes. Now, this can grow in the lungs, unfortunately, causing pain in the chest, shortness of breath, and can be life-threatening, as you can imagine. Okay, another mycosis. This one is histoplasmosis. It's also systemic. This one really blurs the line between skin and respiratory, but I thought I'm just going to get all the mycosis done in one shot, okay? So bear with me. This is called histoplasmosis. You might have seen a patient with histoplasmosis if they were, again, immunosuppressed, if they were on chemotherapy. It's called histoplasmosis because it's caused by Histoplasma capsulata. Here it is. This is a yeast-like organism. Okay. And it is very slow to invade, and it doesn't tend to bother us. You and I could hopefully go walking up and down this riverbank, and in the air, there's going to be lots of dust particles and lots of different fungal spores in there. But it wouldn't be a problem even if it was Histoplasma capsulatum. But for your immunosuppressed patient, this could be life-threatening. Okay? So you can also get this, your farmers kicking up, as they're plowing, they're inhaling, what's in the soil. So they can get histoplasmosis very easily as well as other fungal organisms. This is why when you have patients on chemotherapy, especially the farmers, you're going to have to tell them to wear their mask. They're not going to want to, but you're going to have to tell them what can happen. Because I'll tell you what, once this thing goes systemic, this is bad. So it causes a lung disease, fever, chills, chest pain, wheezing, shortness of breath. It does cause a rash as well, usually. Okay. So we're still kind of keeping on the skin diseases. Transmission, like I said, spores in the soil along riverbanks and all other places. Little FYI, this is very common in older and sick animals. It is the most common fungal disease diagnosed in dogs, by the way. Don't need to know that. Here's another one you can get and your farmers need to look out for when they're breathing in the spores. This is Cryptococcus neoformans. This is a real yeast, and by golly, it has a capsule, which means this is really bad because the immune system is not really going to see this. This one is very common. This fungal disease is associated with wild birds and pigeon droppings. So if you have a patient that is coming in and they keep birds and they have a terrible chest pains and coughing and all of that. Okay, that might be it. So it is a lung disease, but this one also can give you blurred vision, confusion, fever, chest pain, especially in the breastbone, a non-productive cough, possibly with bloody sputum. Here's a chest x-ray, and you can see there's so much inflammation, not a lot of area to breathe. Also, a rash does appear with this one as well, interestingly enough. So this is bad. And again, these are systemic. So you're going to have to give the patient a poison that is, again, it's going after a eukaryotic cell. And these are eukaryotic cells, and unfortunately, you are made of eukaryotic cells. So these drugs can be extremely toxic, but understand something. These patients are very critical right now. And you know what? Give them the drugs, whatever they need. And, you're just going to have to deal with the liver and the kidneys later on. Really quick, there is something called farmer's lung, which could be caused by all the things I've mentioned and then some. Lots of fungi can get into the lungs and cause farmer's lung. But the biggest cause is aspergillus. So it's common in the grain. Here it is growing. Here it is under a microscope. So it is a mold and it's inhaled, found in decaying vegetation and grain bins around this area. The syndrome, it's a terrible inflammatory disease of the lungs. And of course, penicillin won't do the slightest against it because penicillin works against what? Bacterial cell wall PBPs. Yeah. So does a fungus cell have a bacterial cell wall peptidoglycan? No, it won't work. So again, this is going to affect your immunosuppressed patients, your diabetics, your cancer patients, and particularly people who want to go out in the garden or farmers who don't want to stop. Okay. Here's the really bad part about this. This can go into the brain. Most of these organisms, again, keep in mind that none of them have to be pathogens, but a few of them really can go to town and cause lethal results. So here, this is an autopsy. As you can tell, the necrotic black areas and the bleeding out of the brain. So this is bad. Okay, what type of agent is this? A worm, a virus, a mold, a yeast, or a bacterium? It is ringworm. Nah, it's a mold. Okay. These chemicals come from fungi. Some are carcinogenic and some are psychotropic, like they make LSD, or it is LSD. So is this a mycosis, a mycotoxin, mycology, or candidiasis? Mycotoxin, of course. Okay. Which of the following is another name for vaginal yeast infection? Cryptococcosis, farmer's lung, mycotoxin, candidiasis, tinea, sporotrichosis. Of course, it's vaginal candidiasis. Good. D. How is candidiasis transmitted? Through respiratory particles, fecal, oral. It is part of the normal microbiota, casual contact, a cut or abrasion on the skin. C, it's part of the normal microbiota. This, as well as many of these things, are opportunistic. They're there already. You just messed up your normal microbiota and or something happened, okay? So they're there already. But it can also be fecal oral, just so you know. Which is true concerning fungal organisms and mycosis? Okay, so A, they are very strong, virulent pathogens even in healthy humans. B, they tend to be opportunistic. C, they prefer warm temperatures. D, they are not common in the environment. B, they tend to be opportunistic. Not always, but usually. So again, normally they're not going to attack happy humans. They tend not to like the warmer areas. They like it a little cooler. They like it moist too. And they are extremely common in the environment. Okay, what is the clinical term for ringworm? Toxoplasmosis, tinea, tania, cryptococcosis, sporotrichosis. That would be tinea. Tania is actually a parasitic worm. And cryptococcosis, no, that causes yeah, that's not it. Okay. And sporotrichosis would be what? Rose picker's disease, right? Okay. Which of the following is most likely to cause an opportunistic but systemic respiratory infection? Candidiasis, Candida albicans, tinea, histoplasmosis. Okay, so candidiasis and Candida albicans, pretty much the same thing. No, these guys are not going to be systemic, and neither is tinea. So, because that's ringworm. So histoplasmosis, D. Respiratory diseases. Yay, there are so many. I'm just going to have to do the best I can, you guys. But with these guys, think inflammation. All right. So first will be the viruses, then we'll move to the bacteria. First of all, cold viruses. There are two. One of the cold viruses is known as the adenovirus, and that causes spring fever, or it's a spring fever virus. This is a non-envelope virus, so it can hang out on all kinds of surfaces, doesn't easily die. Transmission through respiratory droplets and fecal oral transmission as well. Syndrome is spring fever virus. Now, you probably wondered, was that really a thing? How did that get its name? Is it just because we get it because we want to go outdoors and we're stuck inside and we get infectious diseases? Sometimes. But no, this happened because actually it was named after boot camp and spring training. So you put a lot of usually young men, in tight quarters. They're stressed, their hygiene is bad, they're coughing, they're sneezing, they're touching everything. And remember, it's not only respiratory droplets, but also fecal oral. So it's just a wonderful place for a virus to hang out, and it'll go all the way through the barracks and cause spring fever. And there you go. Okay, so symptoms, cold with respiratory symptoms. It can cause diarrhea, but also if you rub it into your eye, it can cause a viral pink eye, also known as conjunctivitis. So conjunctivitis is pink eye. Complications, this one can go up and cause viral encephalitis. And there's nothing you can really do. Well, there are a few drugs, antivirals for this one. I take it back. Rhinovirus is the common cold virus. There are hundreds of these, and they mutate so very rapidly because they're RNA viruses. So yeah, even when you get memory cells against one, they mutate and they change, and it just doesn't work anymore. So we'll never get a vaccine against that. But these are non-envelope viruses. Again, they can hold out on all kinds of surfaces, all respiratory, so it's not oral fecal. The syndrome is the common cold. So think rhino, rhinoceros, nose, common cold. Complications, really not a lot that we know of. It could really bring down maybe your defenses. You might get a secondary infection. Something else can move in. But, for the most part, we say it's self-limiting and you should be okay. Oh, there it is. Sorry, there's the pink eye or conjunctivitis. The conjunctivitis is just an inflammatory response of the conjunctiva. It can be caused by many different viruses and amoeba and bacteria. Okay, all right. Influenza viruses. We had a little taste of influenza earlier. Let's go into this. So influenza viruses, these are enveloped, but that means they don't last long on counters, but they're in the air. So somebody sneezes behind you, achoo, and then you got the blow by, right? Okay, so sneeze into your sleeve. Influenza is not the stomach flu. Stomach flu is a misnomer, although it is true that some children will get influenza and get GI symptoms, and possibly adults in very violent cases, but this is respiratory. Respiratory, okay? Respiratory droplets. There are three types, three genera. And you know this because you see this on the vaccines you give your patients. You'll see influenza A, B, and C. What are the differences, you ask? I will tell you. Influenza A, this is found in humans, but also pigs, birds, and horses. I'm going to come back to that. Influenza B and C is only in humans. Okay. Now, check out the H and the N proteins here. So we've got, here we go. We've got hemagglutinin, which is a little protein spike, and we've got neuraminidase, which is another protein. So, hey, is that where H1N1 comes from? H in hemagglutinin, N in neuraminidase? Yeah. Each type of virus, each class has different kinds of H's and N's, and that's how we classify them. Okay, let's move back to influenza A. Influenza A, the reason I have this highlighted is because it does jump ship. You can get this from pigs, birds, and horses. So humans get it from animals, and this causes emerging diseases. Those are the scariest. That would be emerging diseases include, oh, Ebola and HIV and SARS and lots of other ones. So anything that jumps from an animal to a human is bad. And influenza A is one of those that can do that. Doesn't always, but it can. So again, influenza A, normally the typical kinds are just going to affect the upper and lower respiratory tract, maybe the GI tract, but you get your inflammation. Okay? All right, so transmitted again, this is a respiratory disease. You are contagious a day before symptoms. Dang. So during incubation, you're contagious. Symptoms, like I said, it is a respiratory disease. It's not the stomach flu. Fever, usually high, but I've had influenza A and didn't have any fever. And my doctor was so smug to let me know that I had influenza because she knows what I does. She knows what I does. She knows what I do for a living. And she's not an infectious diseases MD. So she was right and I was wrong and I was hot and she knew it and she loved it. I love my doctor, by the way. Headache, though, extreme tiredness, a dry cough, sore throat, runny nose, and stuffy nose and or stuffy, muscle aches. Viruses are very good at causing muscle aches. Like I said, stomach symptoms such as nauseousness, vomiting, and diarrhea can be there, but it's more common in children. This is more respiratory. And again, we have a vaccine, but because this guy mutates all the time, we need a new vaccine every year. We have to guess which viruses are coming a whole year ahead of time. And then usually we use a combination of influenza A's, B's, and C's, depending on what we see coming. So the antiviral, okay, that we have is the neuraminidase inhibitors. But what did we learn about those? So Tamiflu, you only have to know about Tamiflu, which is a neuraminidase inhibitor. It's under a group of drugs known as this oseltamivir. So what you need to remember is Tamiflu only works within the first 24 hours after onset of symptoms. This is usually true of all of the neuraminidase inhibitors. Neuraminidase inhibitors, what are those? Okay, remember what? Oh, here. Neuraminidase, that guy, right? Okay, keeps the virus from escaping. But it only works again if you catch it. The problem is the first 24 hours you think you have like another cold, you have a cold. You don't think it's influenza, so it's going to be too late. And Tamiflu, yeah, it can cause neuropsychiatric events, especially in your elderly and in the very ill people. So I'm not a fan of Tamiflu. Okay, seasonal. When you get seasonal influenza, it's probably B or C, and it goes from human to human to human. We're sort of kind of evolved to handle B and C because they're only within humans. No big surprises. Nothing that's going to cause a big cytokine storm. So about 5 to 20% of the population gets just the regular seasonal flu. Approximately 200,000 people are hospitalized from influenza complications each year because this brings down your immune response. So you are susceptible to all kinds of things. Okay. By the way, again, 36,000 people die from the flu every year. And that's an old statistic, but I couldn't find the updated CDC one. Sorry. Funding, right? Pandemics are usually from influenza A because it causes a cytokine storm. What are cytokines? Those are all of the battle signals, right? All the white blood cells talking to everybody, talking to parts in the body. You get a cytokine storm, and that can produce hypoxia. So you can see this person has severe cyanosis, septic shock, heart failure, actually multi organ failure. This is how bad this can be. Okay, so this is actually an illustration from, well, it actually is supposed to refer to something that happened in 1918. What happened in 1918? We had an influenza pandemic. Which influenza would it have been? A, B, or C? A is correct. So, yes, this was one of the, well, this was without a doubt the worst um, case scenario of influenza that we had in human recorded history. So, okay, so this is influenza A, but this is a pandemic. What's a pandemic? It means that it went worldwide, it went global. Now, epidemic means in a certain area. We have normal flu outbreaks, epidemics, but pandemic is worldwide. HIV is currently a pandemic. Okay, so we called this 1918 flu the Spanish flu. And the symptoms again, cyanosis, severe obstruction of lungs, coughing up blood, hemorrhaging, suffocation, and death. You can see there weren't enough, there's no hospital beds. And these are the lucky ones. Most people are outside. This is bad. By the way, it's called the Spanish flu because we were fighting World War I and nobody wanted to let out the facts that there was influenza going around our troops. And so we sent the troops in small confined ships overseas, and it spread the influenza all throughout Europe. But we were fighting World War I, so we didn't want to own up to it. Nobody did, except for the Spaniards who went, "Hey, this is flu." Spanish flu? Spaniards. No, this started, guess where? Okay, yeah, United States, but no, in Kansas. It started in Kansas, where we had some training going on with our troops. Okay, so here are just some of the pandemics. You can always remember influenza A is the pain in the, okay, this is the bad one. So Spanish flu, H1N1, hemagglutinin neuraminidase. This is 1918 to 1919, caused about 675,000 US deaths and more. This is just from influenza. It doesn't tell you what they died of because they went back to work too early and got something else, because this does suppress the immune response. There were 50 million deaths worldwide, again, just to influenza, not to secondary infections. In the 50s, we had the Asian flu. We got 70,000 US deaths, 1 to 2 million deaths worldwide. Hong Kong, and notice how the H's and the N's change. We saw a little less, 35,000 cases of deaths or deaths in the US, 700,000 worldwide. And then, of course, we worry about the bird flu. We did have some swine flu coming through that was a shock, and that was an H1N1. The swine flu that we got, it freaked people out in 2010 because it came when it wasn't during flu season. And they did, the Obama administration said, we're going to declare this a pandemic. And you know what? I'm perfectly all right with this because with education and people saying flu, we haven't had another Spanish pandemic. Yay. Okay, so again, we don't want this. Okay, but yeah, it can jump ship from animals to humans, and this is what happens. I just wanted to talk about some other respiratory viral diseases that you remember, right? Measles virus or rubeola virus, all respiratory, extremely contagious, communicable like chickenpox. You're going to find out contagious a day or even two before symptoms. High fever, sneezing, runny nose, high pitched cough, miserable, inconsolable children, and the rash from the hairline down, in case you forgot. Remember though, this isn't the thing that scares you. This will bring down your immune response and the complications can be very serious and you can get secondary infections and that can be lethal. Okay? And of course, we have the measles, mumps, and rubella vaccine. How about mumps? Also viral, also respiratory. Mumps, you get the swelling of the salivary glands and other glands too. That's where the virus tends to enter and it invades those cells there. You get sneezing and coughing and fever and headache and sore throat. The side effects are deafness. They used to think that this caused sterility in boys, possibly in women, young girls, but that was overstated, really. But it's still not good. It can cause mastitis in the testes, ovaries, and breast. But pancreatitis is bad. Meningitis and encephalitis is bad. So meningitis is the covering of the brain. Encephalitis means it's in the brain. It can cause also a spontaneous abortion in a pregnancy. So this is why we have, oh yes, the MMR vaccine. Measles, mumps, haven't done rubella yet. The vaccine is 95% effective. How about rubella? Viral, respiratory. Okay. Symptoms, mild fever. Okay. Runny nose, but inflamed eye, swollen joints, red rash, and there you go. But okay, it doesn't seem like a big deal, but the problem is in a pregnant women. They get congenital rubella syndrome linked to many diseases and spontaneous abortion. Actually, in a pregnant woman, this happens in about 20% of the cases. But we have a MMR vaccine. Okay. Let's move from viruses to bacterial respiratory diseases. There are so many. I'm just going to talk about a few of these. So let's talk about tuberculosis. This is the biggie. This is by far the biggie. Tuberculosis is found worldwide. It is caused by a bacterium known as Mycobacterium tuberculosis, but you can also get a form from cattle, from especially dairy cattle, called Mycobacterium bovis. The significance, again, you don't need to know the statistics, but no, it's important. Historically, tuberculosis has caused about a seventh of all the deaths in adults in human history that we know of. Today, we still see about 1 billion infected worldwide. That's 20% of the Earth's population, but we still see about 3 million deaths per year. It is on the rise because it's very resistant. It's a resistant bacterium. It mutates and is tough. And also compliance is hard. We'll talk about that. It is closely associated with immunodeficiencies, especially with AIDS. Transmission, it is through respiratory droplet nuclei. What is that? Those are the little tiny particles that have moisture in them that you do not see. Okay. You can also get Mycobacterium bovis from unpasteurized dairy. And what can happen is you can get a primary lesion and in this case, usually it's through the respiratory droplet nuclei. The first lesion is called a tubercle. It is invisible, you can't see it, but it can hide in there. Usually it's inside macrophages and it's hiding in the macrophages, and it will even form a cal, cal, like a calcium walled off little area that we'll talk about later on. Now, it can break out of there for reasons we do not understand and become active. So, the primary complex means that it breaks out of the tubercle, gets into the lymph nodes, and causes lesions there, causing again a secondary lesion. It can go out of the lungs, out of the lymph nodes, and go throughout the whole body and cause something called miliary tuberculosis. Now, you're looking at this going, holy smoke, look at the little dots in here. It actually has the consistency a little bit of little bits of cottage cheese, but this is actually in an alpaca. These are not human lungs, but just to show you miliary, and it's named after millet seeds. But Eleanor Roosevelt had miliary tuberculosis and died of it. So it goes throughout the whole body and affects many organs. So again, this is actually Mycobacterium bovis from an alpaca lung, but same thing can happen with just regular Mycobacterium tuberculosis once it breaks out of the primary complex and goes traveling. So, who is most affected in the US? The homeless, the elderly, malnourished people, alcoholic, poor males, minorities, immigrants, prison populations, and Native Americans. So, if you work in like helping out at the Francis House or Open Door or the Salvation Army Adult Rehab Center, you'll get a lot of people testing positive for TB. That does not mean they have active TB. Okay, it's probably in a primary type of tubercle lesion. Okay, by the way, this is a prison population, not in the United States. This is in Russia. The Soviet Union is really, they are known for tuberculosis and resistant forms. Okay, so prison conditions and all. So let's just talk about the disease course. Like I said, the bacteria are phagocytized by white blood cell macrophages on purpose, but they don't get digested. They enter, but they're not digested. The inflammatory response produces the hard nodules called the tubercles. And here you can see kind of the tubercles forming here. And it could be that the body walled it off and that's the end of it. And this happens in some people. However, the bacteria can remain alive and dormant for years and years and years and years and years. My aunts found out that they were TB positive in their 60s, I believe. Okay, one of the ways to test for this is the tuberculin or Mantoux test. So, what is this exactly? So, the Mantoux test gives you something called purified protein derivative, PPD. What's it? So, these are bits and pieces of the actual bacterial cell, and they've injected it into the skin. Now, what are they waiting for? Well, you see, if you have never been exposed to Mycobacterium tuberculosis, you'll get a little bit of a reaction, a little inflammatory response, but not big. If you have been exposed several times before, you've made enough memory cells, you're going to probably get quite the cell mediated delayed hypersensitivity response, and you'll get a very big type of what's called induration. So you don't need to memorize any of these numbers, but of course, 2 to 3 days is when you take the reading. So 0 to 5 millimeters is negative, 5 to 9 intermediate, 10 is positive. You and your colleagues are going to see a lot of false positives. Why? Well, you're injecting real pieces of the bacterial organism into the tissue. Eventually, your body could say, hey, we have a real infection, and you could mount a real serious hypersensitivity and get something in the intermediate or the positive range. So, so don't freak out. And you also have to tell your patients this. If they've had a lot of manto tuberculin tests, or whatever. It could be they get a false positive. So do not freak out. Okay, the next step is to get a chest x-ray. So, how do you confirm a case of TB? Well, x-rays, yes, but there are other clinical symptoms or clinical signs and tests to do. I just wanted to show you all the little nuclei. Some of these are big droplets, but the droplet nuclei are the invisible ones that can travel yards, feet, okay, uh, and so forth. Mycobacterium tuberculosis spreading throughout the blood to the bone, kidneys, and brain is called primary lesions, primary complex lesions, tertiary lesions, or miliary tuberculosis, also known as secondary tuberculosis. Okay, miliary. Yes, if I had that on a test, it would be miliary. Okay, what is a TB primary lesion? When Mycobacterium tuberculosis is walled off by the lungs, when Mycobacterium tuberculosis is in the lymph nodes, when Mycobacterium tuberculosis is found in the kidneys and brain, when Mycobacterium tuberculosis is found in the bone, when the lesion is detectable by X-ray. And of course, that means that the Mycobacterium tuberculosis has been walled off in the lungs. That's the primary lesion. Okay, so how about something else, you ask? Okay. You get a vaccine for something called Hib. What is Hib? Hib is Haemophilus influenza B, okay? Also known as H flu. Okay, I'm confused. Is this the influenza virus or not? I don't get it. No. Okay, little history. While the 1918 Spanish flu was going on, there were scientists everywhere trying very hard to figure out what was going on. In a lot of the patients who had real influenza, they had this bacterium growing in their nasopharynx, not realizing this organism is very common and and it's really going to take over if you're sick and have influenza. So they thought this was it, and they then pronounced this as Haemophilus influenza, and they never changed the name. But it's bacterial. So yes, you can treat this with antibiotics, sometimes called H flu. So this is a gram-negative, it's pink, gram-negative bacterium. Some of these can live in the nasopharynx and never cause disease and never go deep tissue. Those would be the ones that forgot how to make a capsule. It's probably genetic, they forgot. But the ones that make the capsules are the nasty ones. Transmission, very common in respiratory tracts. You cough, you sneeze, there you go. The disease itself, well, so if you have a population of children who have not been vaccinated, and we did have that before the Hib vaccine, 1 in 200 children would develop the invasive form before age of 5. Of those children, 20% would develop meningitis, so it would get in and cause an inflammation around the meninges, which is the covering of the brain. It can cause joint infection, in some cases even paralysis. But for these children, it is responsible for nearly all cases of epiglottitis. Sorry, the epiglottis is swollen back there. So this can produce swelling of the airways and even suffocation. But golly, we do have a Hib vaccine, Hib, and it is 97% effective, at least in the US. So why isn't it 100%? Because your children are, every child is a little different, right? Right. Okay, how about Streptococcus pneumoniae? This is a misnomer. This guy is really not streptococcal, it's a diplococcus, but it is a gram-positive. Sometimes we call this pneumococcus, and we say that it causes pneumococcal pneumonia, but this is Streptococcus pneumoniae. Morphology, gram-positive, purple, gram-positive bacterium with a capsule. Oh dear. Yeah, oh dear is right. Some people have this in their respiratory tracts. In fact, a lot of people do, but it doesn't cause trouble. But it can. It is very common in respiratory tracts. Again, disease. It is the leading infectious disease cause of death and illness worldwide. It was politically incorrect in the day, and nobody says this anymore, and that's good. They used to call this the old man's friend, meaning that most of your patients who were failing because they had so many health conditions, like cancers or diabetes or whatever, they usually died of pneumonia, and that is still true. And typically, it's going to be Streptococcus pneumonia, and that's what they die of. So they called it the old man's friend, kind of putting an end to the other suffering, I guess. But yeah, we don't say that anymore, or at least not outwardly. Yeah. It's kind of not very happy, but it's the truth. We see approximately 500,000 cases, lung cases per year of Streptococcus pneumonia. The elderly and the immunosuppressed are going to be hit the hardest. So this again shows you the Streptococcus, okay, pneumococcus, because they're really not strepto, they're diplo. But look at the inflammation in the inflamed lung. This is an autopsy. Bad, bad, bad. Of course, we have a vaccine. It's the pneumococcal vaccine. This is just to show you some of the most common pathogens, bacterial pathogens found in a hospital to cause respiratory diseases. So Streptococcus pneumoniae is always number one. Mycoplasma pneumonia causes walking pneumonia, and I don't have the ability to talk about that one. We just don't have time. But Haemophilus influenza is there. And there are other gram-negative bacilli, like something called Pseudomonas aeruginosa, Klebsiella pneumonia, Staph aureus also, very much so. So this just shows you, what's most common in hospitals. Okay, that's it. Thank you. Only one more week to go. Yay!